Ladies and gentlemen, as we are about to begin the program, please be seated and switch your mobile in silent mode. Thank you for cooperation. And I'd like to invite Pushpalata ma'am, Deepika ma'am, CB ma'am, Nemkomla ma'am, and Sabita ma'am on the dais. In a while, we'll be starting our program because our chief guest will be joining all the way from Geneva, so we will be waiting for 5 minutes. Principal ma'am.
Yes, good morning, India.
Good morning, sir. Sir, we are going to start the program in short. We are waiting for the principal ma'am to join online. Thank you, sir. A very pleasant morning to each and every one of you present here. Wishing you a very happy Holi. Itself is an honor itself to honor this beautiful audience who has gathered here. I, Dipumala Devi, MSc second year nursing student, would like to extend a warm welcome on behalf of College of Nursing, Ames, Delhi, who has clubbed all of us here on the in-service education program on managing the outbreak, pandemic, and endemic. First and foremost, I would like to address today's workshop by quoting from the Bible, chapter 46, Psalm verse 122. It says, God is our refuge and strength, and ever-present help in trouble. Therefore, we will not fear, though the earth gives away and mountain fall into the heart of sea. It gives me immense pleasure to welcome our honorable chief guest, Dr. Murali Thumarkudi, Chief Operating Manager, Crisis Management Branch, United Nations Environmental Program, all the way from Geneva. Sir is one of the most renowned, notable, esteemed, and illustrious individual among us today. Sir, it is our pleasure to have you. In spite of your busy schedule and vast time difference, you are gracing our inauguration ceremony. I heartily welcome you, sir. I also extend my warm welcome to our today's guest of honor, Mrs. Pushpalata Ma'am, Nursing Superintendent, NIC Judger. She has a very vast and enriching experience in nursing and is a thorough professional. I heartily welcome you, ma'am. Now I request Anjali to kindly give a token of appreciation to ma'am. I also welcome Dr. Deepika Khaka ma'am, our MSc coordinator, College of Nursing, Ames, Delhi, who is one of the most adoring, motivating, and enthusiastic teacher. Ma'am has been a continuous source of inspiration and encouragement for us. Thank you, ma'am, for gracing today's SIR workshop. I request Mr. Bibin Lal to kindly give a token of appreciation to ma'am. I extend my most welcome to Mrs. C.B. Riju, Associate Professor, College of Nursing, Ames, Delhi, faculty in charge of MSc Neuroscience Nursing. Ma'am is the core of today's organizing team. Thank you, ma'am, for your continuous support and guidance throughout the whole year. Now I request Ms. Parul to kindly give a token of appreciation to ma'am. Now I extend my warm welcome to Mrs. Nimkumlam Tutor, College of Ames, Delhi, and Ms. Sabita Tutor, College of Ames, Delhi. Thank you, ma'am, for always being available. Now I request Mr. Bibin and Ms. Ritika to kindly felicitate ma'am with token of appreciation. I happily welcome all the faculty members, Mrs. Surbala ma'am from Associate Professor College of Nursing and other faculty member, nursing officers who have gathered here and joined us from online from different various departments. I hope that all of you have a productive day of interesting discussion. Light symbolized the victory over the darkness and marked the beginning of auspicious event. So I would like to request all the dignitaries, Mrs. Pushpalata ma'am, Dr. Deepika Khaka ma'am, Ma'am CB, Ma'am Nimkumlam, and Ma'am Sabita to do the honor before Ma Saraswati. May I request a voluntary? Now, may I request Mrs. C.B. Riju ma'am to kindly give the welcome address to the gathering.
Thank you, Deepamala. A very good morning to our chief guest of the day, Dr. Murali, Chief Operations Manager, Crisis Management UNEP, Geneva, who has graciously consented, in spite of the very vast time difference, to be at the inaugural. Thank you, sir. The guest of honor, Mrs. Pushpalata ma'am, NS, Nursing Superintendent, NCI Jhajjar, Deepika Khaka ma'am, MSc Coordinator, and the Associate Professor, College of Nursing. My organizing team members, Ms. Nim Kholem and Ms. Savita. My MSc second year students who have also actively organized this program, Ms. Deepamala and Mr. Bibin. All the faculty members and the participants. I heartily welcome you to this workshop on managing pandemics, epidemics, and outbreaks. Pandemics, they are large-scale outbreaks of infectious diseases that can greatly increase morbidity and mortality over a wide geographic area and cause significant economic, social, and political disruption. We all have seen the recent COVID-19 pandemic and the widespread havoc it has caused and how everything was brought to a standstill. Evidence suggests that the likelihood of pandemics has increased over the past century because of global travel, integration, the biological and lifestyle factors. Significant policy attention has focused on the need to identify and limit emerging outbreaks that might lead to pandemics and expand preparedness in all forms of health capacity building. With this background, we have organized this workshop. The objectives of this workshop are: at the end of the workshop, the participants will be able to have a basic understanding of pandemics, epidemics, and outbreaks, know about the control of outbreaks, pandemics in peripheral healthcare settings, understand the hospital preparedness in managing the pandemics, and also learn how to manage the vulnerable population, especially the infants, the neonates, the pregnant population in the pandemics. With this, I stop here. Thank you all. Have a wonderful learning experience.
Thank you, ma'am. Thank you for your warm welcome. Now, may I request Dr. Deepika, ma'am, to kindly unfold the theme. As we know that ma'am Deepika does not require any introduction. Her name is enough to suffice to fulfill the prouds in the room. Ma'am, I kindly request you to unfold the theme, and I also request other dignitaries and esteemed guests to kindly join the same. Ma'am, I request you to kindly share a few words with us.
At the beginning, a very good morning to all of you. And I would welcome you at this very pertinent topic of today's workshop, which is managing pandemic outbreaks and epidemics. We have currently faced a pandemic which has taught us many lessons. Generally, I remember we used to see this pandemics, in Hollywood movies where they used to show that there was a pandemic and there was quarantine and isolation and people like astronauts dressed up. All that we saw generally in movies, but we had never seen, in my life, I had never seen anything like this, a pandemic who has not left anyone on the planet unaffected. All of us were affected in some way or the other. I will begin by quoting a quote says, "Brave men rejoice in adversity, just as brave soldiers triumph in war." And especially we as healthcare providers have been like soldiers in battling this war against COVID-19, which before 2020 we had not known what is COVID and what is COVID-19. But once we had faced this, we as healthcare providers slept with our boots on. We were on war footing and we handled this pandemic, we know, day in and day out. Talking about new normal, which is a new phenomena, and we are all seeing it now in our daily lives. New normal is basically a state in which the economy, the society settles following a crisis, when it differs from the previously prevailing situation. Like pre-COVID-19, we are not aware what is new normal. We were not very much aware about social distancing, maintaining hygiene. All these protective measures have come into being after COVID-19 pandemic. And pandemic, like we as healthcare providers, play a pivotal role at the community level, at the hospital level, to battle pandemics like this. Management of in these situations of pandemic, epidemics, and outbreaks, the management of situations of like health emergency or health crisis is very important, and it requires coordination at a Herculean level, at various agencies, at the community level, at the hospital level, at the administration level, and we have to combat the situation head on. And the prediction says that this pandemic is now going to be an ongoing phenomena. We are going to have pandemics on regular intervals. So we have to be prepared as a healthcare professionals to face any kind of health emergencies, outbreaks, and epidemics or pandemics at regular levels. Though we have learned a lot from COVID-19 and we are now better prepared than we were before the coming of COVID-19. Do you agree with this or not? It has taught us many lessons. Like I remember in first wave, we were very casual because I remember there were a lot of casualties in the West, in the Europe and America, and we thought we are more resilient, we are more immunologically better because we have tuberculosis and many other kind of airborne infections we are facing. So we are maybe immunologically more stronger than the Caucasian population. But in second wave, we learned our lessons. Second wave caused a lot of catastrophe and we learned from second wave. So when third wave came, we were better prepared in relation to our oxygens, in relation to the, there's a lot of coordination we know is required in relation to the supplies, in relation to the coordination between different departments, in relation to the manpower planning. So with this, to further deliberate, I would really welcome you all for this deliberations, and we have very galaxy of experts who are veterans in their area, and they will be speaking on these topics. And once you leave, you will be better prepared, better empowered, better will have a better store of knowledge regarding what to do in wake of such situations like epidemics, pandemics, and outbreaks. And I would really congratulate the organizing team for taking up such a pertinent topic, which is very pertinent in our everyday lives now. Thank you.
Thank you, ma'am. Thank you for your amiable words. I also welcome other faculties, ma'am, from the College of Nursing. Welcome, ma'am. Now may I request our Honorable Chief Guest, Dr. Murli Thumarkudi sir, to kindly share the inaugural speech. Sir has over 30 years of international experience in the field of environmental and disaster management, United Nations environment. He is a part of United Nations since 2003. Sir holds PhD in environmental engineering from IIT Kanpur. Sir is also alumnus of International Leadership Academy from United Nations University. Sir has managed projects in major conflict and disaster area of the 21st century, including Afghanistan, Iraq, Lebanon, Sudan, Congo, Japan, India, etc. Sir also wrote various novels in Malayalam language and was awarded as a Kerala Sahitya Akademi Award winner 2016. And there are uncountable contributions towards the society that Sir has dealt in part. Sir himself is a futurist technologist, enthusiast, storyteller, mentor, and public speaker. So we are very grateful to have you here, and will you kindly share a few words with us?
Good morning, India. Can you hear me?
Yes, sir.
Okay. Okay. Very good. First of all, I want to thank the organizers for considering me to be a speaker in your very of COVID. And all world is also gradually coming onto this pandemic. Hopefully, this is the last major wave which we have to face. Even though there's a prediction of a fourth one in June, by and large, the world seems to be returning. Before I start my formal lecture, I want to thank all the nursing community who are present here. As Pushpalata Madam said, it was like war. It was something which was unprecedented, at least in our lifetime. It was the biggest crisis faced by our generation of our leaders, generation of our doctors, generation of our teachers, generation of our parents. It was probably the biggest thing which we saw after the Second World War. The two generations have not faced anything similar. But it was even bigger than Second World War. The Second World War never affected all parts of the world at the same time. Even as fighting was happening in Singapore, India was peaceful. Even as fighting was happening in Egypt, other parts were safe. But COVID-19 was not like that. COVID-19 affected all member states of the United Nations almost simultaneously. Starting off in China in 2019 December. By March 11, 2020, WHO had announced the global ban. By April 2020, COVID had reached the entire globe. None of the 193 member states spread. So when something this variety happens, our healthcare community, nurses being right in front of that community, they were not as prepared as we are now, as the madam said. Partly they were not trained for it, partly they have never experienced anything like that, and partly in many parts, as the madam said, people assume that we have some sort of an inherent immunity, not our problem, etc. But you face that challenge head on. Even as the science was not very clear exactly what's happening, even as the provision of supplies were not enough, including for personal protection, even as people were dying all around you, even as you could not meet your family, even as community in some part of the world, unfortunately, including in India, were keeping you untouchable, you still stood up and fought this battle. And we are winning, and we should all be proud. Many people, unfortunately, lost life. Millions of people lost life in general, but thousands of healthcare workers also lost life. If you take the statistical average of the number of people who died vis-a-vis the total population, and the number of healthcare people who died vis-a-vis their total population, clearly a high proportion of those in the healthcare sector died. And this is a battle which you fought for us on behalf of humanity. And I want to acknowledge the fact that there is not even one nurse anywhere to my right said, oh, I'm not going to work today because I'm afraid of my life. Of course, you have all had personal circumstances and challenges. Young children, old parents, your own vulnerability, pregnancy, but still, you stood up. When this crisis was incoming, and I often attempted to speak, a number of my friends who are doctors, nurses, health inspectors, I used to keep in touch with them almost every day. In fact, multiple times. And I was always used to tell them, this will end, for sure. Everything ends, everything has an end. First World War ended, Second World War ended, plague ended. Clearly, this will end. But when this will end, we don't know who all will be left. Hopefully, most of us will be left. But when this is all over, we will be able to look back and say this was the most defining period in our life. We got an experience with no generation before us received. And in the decades to come, you will be seen as the generation of what they call the battle-hardened soldiers of the pandemic. And that will give you the type of confidence which the new generation can only dream of. Because you have dealt with something which had no rule book. There was no seniors to advise that this is how you handle. So, as we say, the United Nations, you were flying a helicopter as you were building. But you have managed that successfully. The helicopter is now landing safe. Of course, we should keep the vigil on, but we have to also prepare our new generation of students and practicing nurses how to deal with pandemics in the future. Because pandemics will come and come for sure. My first exposure to an epidemic like this was unfortunately in 2009 when I went to China in the context of an earthquake which happened there. I was picked up at the airport and put into quarantine. This was in H1N1 day. I did not even know the word quarantine at that time. Nor did my family, nor did my friends. And it was a traumatic experience that you are isolated and you have no connection to the rest of the world. So I had some sort of a preview to this incident. But most of us were not prepared when it hit us. But we have to learn almost everything right from start. The early days, as I said, there was a shortage of even personal protective equipment. Very rapidly, things got stale. Now, luckily, every country in the world has learned lessons, is learning lessons. The international community, in totality, also learning is less. The World Health Organization and the member states are working together on what we call a pandemic treaty. So that the next time it happens, we can all be better prepared. How do you inform each other? How do you share resources? How do you coordinate when you do border closures and so on? So that we do not have the type of human tragedy which we saw, not because of the pandemic, but because of the actions taken to restrict the pandemic. Stopping of the trains, stopping of the planes. My friend who's stuck in an airport for 83 days, you're seeing people walking 1,000 kilometers on railway tracks, some of them even dying. So there is a global pandemic treaty coming so that this can be better. But of course, everyone has to look at how to deal with the pandemic in their own context. We, on the environmental side, is looking at how is that the environmental damage which is ongoing, including the climate change, likely to cause more pandemic and how can it prevent? Two out of the three new virus jumping, affecting human beings are jumping from animals, zoonotic. So the more environmental destruction is there, the more chance that we have newer pandemics. So this is one area where we are working on. How do we ensure that environmental destruction is minimized, human-animal interaction, that context is minimized, the chance that another disease will jump into human is avoided because of the consequences. In your own community, nursing community, I'm sure you are looking into what are the lessons which you learn. As much as today is a training, I also hope this is a discussion where you listen to each other to understand what are the basic lessons you have learned. One good thing about this pandemic period is that it has made education global and online. The very fact that I'm sitting here in Geneva early in the morning and talking to you, the technology was already here, at least for 10 years, but we never used it. We are all in the dark. Online teaching was possible at least 10 years back, but we are not using it. But now, online teaching almost become the norm. What it means is that the students and the practicing nurses now have an opportunity to learn from the best teachers, as well as the best curriculum anywhere in the world. The new education policy in India also facilitates that you are allowed to take online classes from anywhere in the world and claim credit for. So if you integrate these two developments, the phenomenal possibility brought in by online learning, the new policy changes by UGC accepting online credit, what it means is that your students can now learn the best and be credited. But it also implies is that training courses like this, which you are organizing here in Delhi, should reach each of the 100,000 villages and cities in India, because it is needed. Every nurse in India, in fact the world, should hear what is being discussed, because it is relevant to them. And that's the second point, that the world of work and learning is changing so much that it will not be enough anymore that you do a nursing degree or master's in nursing or a PhD in nursing and then do lifelong practice. That is just not going to be possible. So all of us, regardless of the profession, will have to get used to culture of continuous improvement, continuous learning. The nursing and the medical profession always had, engineers were probably less so. But now, times are changing. And online learning also provides that opportunity. So I'm extremely delighted to see that you have picked up the right topic on pandemic response, preparing for pandemic, and is training your youngsters. I encourage you to make such training available if it's being recorded to every other nurses, nursing students in India. And once again, want to thank the nursing community for standing up to the challenge. Without adequate preparation, without adequate equipment, at great personal cost. I thank the organizers for inviting me for this event. I conclude my inaugural speech and I thank you all and wish you a very good training.
Thank you, sir. Thank you so much for sharing your valuable time, those astounding experiences, and precise knowledge with us. I hope today's workshop will help us and everybody to be prepared for the next pandemic or next outbreak. And, sir, we will look forward to more guidance and collaboration with you in future. Thank you so much, sir. Now, I would like to kindly call upon our guest of honor, Mrs. Puspalata ma'am, to share a few words with us. Ma'am is currently working as a nursing superintendent in CI Jhajjar. She is a registered nurse with more than 31 years of experiences, served as an administrator more than 10 years, and a member of various committee of the institutions, held a membership in various professional body and attended various national and international conference, held a major role in establishing NCI in Jhajjar, converting a cancer center to a COVID care center in emergency during pandemic. Ma'am, kindly share a few words with us.
Very good morning to all. Respected Dr. Murli, Chief Manager, Crisis Management. Very good morning to all. Respected Dr. Murli, Chief Operation Manager, Crisis Management Branch. Madam Dr. Lata Venkatesa, College of Nursing. Madam Deepika Khaka, Associate Professor, College of Nursing, and organizing team members and participants. I would like to convey my heartfelt gratitude to the organizing team for inviting me here in this program. I use this opportunity to thank all the physicians and healthcare professionals for their hard work, thoughtfulness, and commitment during the challenging time of COVID-19. Fortunately, we made significant progress in understanding this disease, and we have developed our abilities to combat with me, to serve patients in an efficient way. As I had lead the team in this pandemic, I can say that this was not an easy task for the administrator to train and educate their workforce in this pandemic. 2 years back, when almost the entire world was in lockdown, we the healthcare professionals were really working hard to take care of these patients. We are really not aware about the treatment, spread of the disease, and precaution to be taken in the initial stages. I have been multiple times. There is a need of educational program of this kind to sensitize my team members to motivate and prepare themselves for this kind of pandemics. Although we all have been taught theoretically about the management of outbreak and disaster in our training time, but physically doing this is real was quite challenging. I am glad that College of Nursing has taken initiative in conducting a session especially for nurses to update them on a very important topic, which we can see in the need of this hour. I congratulate the organizing team and wish the good a very successful event. Thank you.
Thank you, ma'am. Thank you for your amiable words. I also would like to inform that our esteemed guest, today's resource person, Dr. Anand sir, and Dr. Rajiv Das Gupta is with us in today's inaugural ceremony. Thank you, sir, for coming. Now we have come to the end of our inaugural ceremony. So I would like to call Mrs. Nemkhomra ma'am to kindly share a word of thanks with us.
A graceful and a warm morning to our most beloved guests, worthy faculties, last but not the least, all gathered over here. It is my privilege to have been asked to propose a vote of thanks on this occasion. First, I would like to thank our Lord for his countless blessings and making the day a magnificent one. I extend a very heartful and hearty vote of thanks to the chief guest, Dr. Murali, Chief Operation Manager, Crisis Management Branch, UNEP Geneva, who spared his valuable time from his busy schedules to grace the occasion. I also thank the guests of honor, Ms. Puspalata, Nursing Superintendent and CI AIMS Judger, for her solid support and timely monitoring in every aspect as we grow. It is your appreciation and words that enthuse us in all our efforts. I thank Professor Dr. Lata Venkatesan, Principal College of Nursing, for her minute-to-minute support, guidance, and for encouraging us at every point of time in the organization of these great events. I give my sincere thanks to our senior most faculty, Dr. Deepika Khakha, Associate Professor, and who is also the MSc Coordinator, for awakening the passions and desire to support us as a ladder to reach the pole of success. Your constant encouragement has helped us in all the best way. Thank you, ma'am. Even like this cannot happen overnight. So as the wheel starts rolling weeks ago and require plannings and bird's eyes for detail, I cannot thank enough the MSc nursing students for their involvement and the willingness to take on the completion of the work beyond their comfort zone. We are also very fortunate enough to be backed by a team of a very dedicated and motivated teams from the SET facility who know their tasks and are very much result oriented. I would like to mention my deepest sense of appreciation and would place on record my hearty thanks to all the participants, without whom we could not make this function possible. Thank you very much.
Thank you, ma'am. Thank you for your kindly words. Now I request our ushers to kindly assist our dignitaries for the high tea. And I request all the participants to be seated because we are going to start our sessions in next 5 minutes. Okay, and after the first session, we'll have a tea break for the participant.
Second thing is that this pandemic is becoming more frequent. So it is neither the first thing, nor, as you can see, this is the pandemic in India in 21st century. Hardly in 20 years, we have had many such outbreaks. We never had this kind of thing when we were being taught public health. Hardly there were any pandemics that we could talk of. Maybe some epidemics of meningitis, meningococcal meningitis and something like that in some part of the country, but definitely nothing which of such magnitude. So these are becoming much more frequent. We have to learn to manage them better, right? So that's this point number 2. So now just before we go further, these terms are often used. What is endemic, what is sporadic, what is outbreak, what is epidemic, what is pandemic. So as you can see, endemic is something that occurs at a steady rate among a population. So we know that this is the number of cases it will occur, and we can easily predict the number of cases. Sporadic actually means it just occurs once in a while. We don't really need to do anything about it. It will occur once in a while and we can deal with it. Endemic means that it is occurring on a regular basis, though on a smaller number. It doesn't become a problem. The system learns to deal with endemic problems. Outbreak is that one occurs above a threshold. So very often, if you know, as I said, if you can predict how much will occur, we also use what is called as a threshold. If the number of cases go beyond a threshold, that means that it is increasing and we should be prepared for an epidemic. That threshold will vary for different diseases depending upon its level of endemicity. But we can draw these thresholds earlier in knowing the frequency of occurrence. Once they cross that threshold, they become an outbreak. And if that outbreak becomes wider in geographical area, it becomes epidemic. And pandemic is by definition if it occurs more than one continent. It has to go beyond a continent for it to be called as a pandemic. So that's how we differentiate between these 3 or 4 terminologies. I'm not sure how much of this is taught to you in your curriculum, so maybe I'm repeating something which you already know. So we can take some examples of the common epidemics which occurred in recent past. For example, Ebola occurred in recent past, right? Again, you can see, and we will see this in the next 2 slides also, that largely most of these keep occurring in a animal kingdom. These viruses keep circulating in animal kingdom. Depending upon which animal is involved, they get affected, they die, but humans are not affected. That cycle keeps on happening in the zoonotic cycle keeps on occurring. Only when human come in contact with such situation that a human case will occur. If you don't go to where that area, largely they are in forested areas, if you don't go there, man will never come in contact with them, humans will not be affected at all. That circle will keep happening there and we don't have to bother about it. But unfortunately, more and more humans are encroaching the forest. We are more and more going into the forest for whatever reasons, livelihoods, for commercial purposes. And therefore, our contact with animal cycle is increasing. And chances of humans getting infected is increasing. So this is what we saw in Ebola, where bats was the affected or the animals which were involved. Similarly, if you look at the Crimean Congo hemorrhagic virus, again you can see wild animals. There is a cycle in the animals, which is you can see in the above. Humans are not affected. Only when humans eat meat which is infected with this, that's we got infected, and therefore again this human cycle starts. Same was also true for Nipah virus. Where did we report Nipah virus in India first time? Kerala, yeah. So again, largely the ability to detect a pandemic, which I will not focus too much on, but the earlier we detect a pandemic, better is that we are able to manage it, right? And what is the way to detect a pandemic? Any pandemic? How will you detect any epidemic or outbreak early enough? Sorry? By what system? So you have to have a good surveillance system in place, right? Where you are monitoring. If you are not monitoring, you are not measuring, you cannot pick up such things, right? So you have to have a system by which you monitor these kind of situations which are occurring. And if you don't have, and we'll come to that again later, then we will probably intervene too late in the course of the epidemic. So again, you can see as you know, we were not able to absolutely clearly identify, but it was postulated that bats are involved in the Nipah transmission. So another thing that is happening is that even though humans are going more into the forest, but also, as you can see, we have increased man-animal contacts because, especially in East Asia, in China and those countries, you have these live animal markets where they sell exotic animals. So they bring it from the forest and sell it here. So now humans also don't need to go to forest. For such contacts, we are bringing them and enabling a much better contact. As you know, this was one of the reasons of why the Wuhan animal market is probably the origin of this. So you get many animals of different nature, bring them all together, put them in one place, which is usually quite crowded with humans. We are creating an atmosphere where such kind of viruses will spread. Right? Second is increasing globalization of good, whether it is meat or egg. It is produced in one country and sold in some other countries. This kind of globalization means that the disease can spread very quickly, even if especially if your systems for safety are not that good, then these viruses can easily spread between countries through these kind of food products. Increasing global travel, which again we saw. Infected person takes a flight, goes to some other country, and there is so much travel from different countries that by the time we know about it and stop travel, most likely somebody or else has already moved beyond the country and has infected somebody else in some other country. So it is becoming, previously it used to be much easier to do this. Nowadays it is extremely difficult to stop global travel. This is also related because no country wants to report an outbreak in the global context. Like one of the reasons why, whether it is China, it will also happen in India if it happens. We don't like to be seen as, because it is seen as a negative. Like even you will see in South Africa, they reported the variant and everybody jumped on South Africa and banned flights. So today there is no incentive to report early for countries. They just get branded and they get, there is an enormous international censor sort of a thing. Unless we report early and take action early, you cannot do much. Otherwise it will spread very quickly and then you are too late. It will become a pandemic and you are too late to do anything about it. Unfortunately, global system currently is not very encouraging to report early, right? That is why countries, they take time to confirm because nobody likes to report without confirmation. Confirmation itself takes maybe a week or 10 days. You will send it to a lab. Lab capacity is not that good, especially for new viruses, right? You will need a much better lab capacity. By the time you send that sample to somebody in a good lab, get it reported, already 3-4 days would have gone. By the time, maybe I don't know how many travelers would have traveled across the world, right? So, and most of these viruses are now respiratory borne, which is far more difficult to control, right? Especially by flights and other things. So, all these are making our lives very difficult, and therefore we should be ready to be dealing with pandemics in future, many such pandemics in future. We will continue to deal with COVID, but also more pandemics will come in future. Okay, so as I said, viral transmission keeps occurring in reservoir animal hosts. We don't have to bother too much about it. If we can monitor them, especially if viruses are changing, then we can have a surveillance system where we monitor the virus cycle in animals, right? That is not to identify, do anything, but to know which viruses are circulating, so that we can quickly move towards a diagnosis if it affects human beings. Then an index case, which is the first person who gets infected from the animals. Till here there is not a problem. If there is 1 or 2 people get infected, there is no problem. You take care of them, you isolate them, you can do it. But once human to human transmission starts, one human being spreads the infection to another being, the potential for control becomes much difficult, right? And that is where most of the problems will lead up to. So our ability should be that we pick up before a human-to-human transmission occurs and control it. Otherwise, once it goes human-to-human, then our first line of defense is gone. We'll have to go up to second line of defense. And if people have traveled, then your all lines of defense are gone. You have to now face a pandemic, right? So as you all know, this is what is called the transmission chain, right? Pathogen, reservoir, portal of exit, modes of transmission, portal of entry, and susceptible host. A susceptible host, if he gets infected, becomes a potential source for the next person, if human-to-human transmission is there, right? So this cycle keeps happening. At each level, we can intervene, right? We can intervene at pathogen level if we don't allow them to circulate. We can intervene at reservoir level if we control the reservoirs to forest or take actions to control them at that stage. Portal of exit is when you sneeze, as you say, masking and all is a portal of exit control. Modes of transmission, again, washing hands and those kind of things. Portal of entry is when you, again, wearing masks could also be a portal of entry related control. And susceptible host, obviously, vaccine is one way to deal with susceptible host. So these are the different ways that we can deal with pandemics. Okay, some other terms which we often use in pandemics and epidemics. As you can see, in any disease condition, it's infectious disease condition, people have, when they get infected, you don't develop disease immediately, right? After agent enters into body, it takes time to multiply and then enter the system, whichever it is has affinity for, and then you develop symptoms. The time that the gap between the infection to development of symptoms is called as the incubation period, right? Then is also concept of period of infectivity, right? That is important, and we will come to that why. Is that when is the person who is infected becomes infective for the other person, right? That is an important concept. If you are not infective, then it is a dead-end infection. Then you are not going to transmit it to others. If you are infective, then only you can transmit it to the others. So period of infectivity is very important. Now, as you can see in this example, the infectious box goes into incubation period, right? You can see that there is a incubation period, the yellow box. Infectious is partly in the incubation period. So what does that mean? It means that you become infectious before you become symptomatic, right? That is an important consideration for you. For COVID, it is an important consideration. In other words, you are infective during an asymptomatic period. If you are infective only in a symptomatic period, it is much easier. You know you are infected, you can isolate yourself, right? But if you are infective in an asymptomatic period, you think you are healthy. So you will go along, you will infect a lot of other people, right? And therefore, after getting symptoms, isolation will have limited effectiveness because he has already infected other people during the period when the person was asymptomatic. That is the problem with COVID. COVID is infective during at least 2 to 3 days before you develop symptoms. You start becoming infective to the others. The virus is in your airway passages. You cough it out. While you speak, you can infect others. So that is very important. In those phases, that is why traditionally we were saying masking is not necessary for universal. But masking was made universal because you could be infective in your asymptomatic period. You won't know. If only you mask after you develop symptoms, you would have already transmitted infections, right? The other time we use often in this thing is quarantine and isolation. And very often we use them interchangeably, which we should not be using. But that's whether in newspapers or in many public forums, we see them being used. Quarantine is done for, why do we do quarantine? No. See, quarantine is not done for period of infectivity. Isolation is done for period of infectivity. Yeah, quarantine is that you know that somebody has been exposed, they are asymptomatic. You want to know whether they will be actually infected or not. So what will you do? You will, well, isolation as a procedure is the same. So you will put that person in a room, in the sense isolate that person, till the incubation period is there. Because, or maximum incubation period. If the maximum incubation period, the person does not develop symptom, that means he or she has not been infected. Then that person can go home. Traditionally, we do when somebody is coming from outside, from in a country or in a, it could also be done within states. When somebody comes from an area where this disease is endemic or epidemic, when they enter an area, geographical area, you can stop them at the border, ask them to be isolated for incubation period, maximum incubation period, and then if they are asymptomatic, then they can go home because they are not infected. So quarantine is done for not ill people. They are not ill. They are perfectly healthy. If they are healthy, which is, if they are ill means they already have symptoms. You will not quarantine them. There is no point in quarantining them. You will isolate them maybe or treat them. So they are completely, people who are healthy people are quarantined to see whether they develop the disease for a period which is equal to incubation period, right? Whereas isolation is done to prevent you transmitting infection to somebody else. Therefore, period of isolation is dependent on period of infectivity. It has nothing to do with incubation period. You will isolate patients for the period when they are likely to be infective. They may continue to have the disease if they stop being infective, but they can still continue to be diseased. But then they don't need to be isolated. For COVID, it is the initial, we said about 2 to 3 days before symptoms and about 5 to 7 days after symptoms is where you are infective. After that, you are not passing viruses in you. That's why we, even for deciding how many days, if you are positive, how many days you will stay at home, we use the period of infectivity. We don't use incubation, right? So, you may still have disease, you may need rest for other conditions, but as an for spreading the disease to others, which is what as a healthcare provider we are interested, we use the term period of infectivity, right? The other important, at least COVID taught us, is the asymptomatic disease. Largely initially, it is very difficult to know how many proportions of, what proportion of the infected develop symptoms. If everybody develops symptoms, then we are much easier. We can pick up conditions much better. If very few people develop symptoms, majority are asymptomatic, which is largely true in, or very mild symptoms, which is what we see in at least in the Omicron phase, then people will go on living their normal life, they will keep spreading, right? So proportion of asymptomatic is important in terms of ability to control the disease. If it is fully symptomatic, then we have a better chance because we'll recognize patients faster and can isolate or control them much better. So these concepts are important in infectious disease epidemiology. The other concept, I'm sure you would all have read about this R0 and transmissibility. A lot of this thing happened. I don't know how many of you. So what is the likelihood that a infection will result in an epidemic? Is decided by that it's the nature of the virus, right? or bacteria, any of agent. How transmissible is that? How easily that virus or bacteria can be transmitted? Is basically, if you say, if you close everybody, take a family, introduce the virus into one person, see how many others get infected. That will tell you how transmissible the disease is, right? So how many people can one person infect is what is called as R0. If assuming everybody is susceptible, right? Obviously, it is not necessarily true, everybody may not be susceptible. But in a situation where everybody is susceptible, if one person gets the infection, how many persons will that infect? If it is more than one, that means that it is going to multiply, right? In an exponential way. Because infections go exponentially. I give to two give to 2 each. So 1, then 2, then it will be 4, then 8. It goes off in an exponential way. Infections in a community multiply in an exponential way. Therefore, infectivity, if it is more than 1, it will rapidly move. Higher the R0, more faster is the spread of the epidemic. Because it will infect more and more people, and they will spread more and more people, and it will keep on happening. Obviously, it also depends on the what we call as a serial interval, how long, or to some extent incubation period. How long does it take between one infection to the other infection, right? That is the serial interval. So based on transmissibility and serial interval, we can, most models that you use for the COVID, use these two basic concepts in modeling. What is the R0 and what is it? What was the word? A serial interval, right? Maybe if I am going too fast or too high, let me know. I'm trying to keep things simple. So whenever we plot as an epidemiologist, we plot. You all must have seen lots of curves, right? During COVID. The lower curve is what is true for COVID, which is actually the upper one is for COVID, which is a propagated epidemic. Common source epidemic is what we usually deal with, and well gets infected by cholera. Everybody who takes water from that well gets infected, and epidemic. That's a common source. Everybody can be traced to one source, right? And then generally, these people can again maybe spread to the others, but generally that dies on very quickly, right? But a propagated source is you get infected, you infect somebody else gets infect somebody else. So that way you will have multiple waves keep on happening, right? That's what we are seeing in COVID. So it's a propagated epidemic. Okay, so see, these are the two curves. The first one, if you look at, that's how usually any epidemic comes. It goes up. Even if you do nothing, epidemic will come down. Any epidemic will never continue forever. All epidemics will go up and come down. It will come down because the pool of people whom it can infect will be exhausted in that population. Everybody gets infected, then that agent has nowhere to infect. So automatically things will go down, right? So do nothing also, the epidemic will come down. So whole challenge of managing an epidemic is that it does not go too high. We stop it when it is much lower, or what we call as a flattening or plateauing the curve, right? So whole purpose of outbreak management is to plateau the curve. Don't let it go like this. Let it go like this, right? That how much below we can depends on when do you intervene. See, initially it goes like this. So depending upon where you intervene, how fast you intervene, flatter will be the curve. That is the most important reason why we should pick it up early. If you pick up early, the curve will become flatter earlier. If you pick up late, then very often we pick up when the peak is almost close. Then you do anything, it is going to make not going to make any difference to your curve. It will go up and come down. Very often in COVID we did that. We acted quite late. Even in the second wave, even in the third wave, we did not really act very quickly. So therefore, most of the waves we did not, except for the first one, because of the lockdown, it got flattened, but it was too early. The lockdown was too early when it has not even started rising. So not much effect on the curve, except if we postponed it. We didn't flatten the curve because we did it too early. We postponed the curve, right? And therefore, so the whole, this is not easy. So unless you have good systems in place and good way of you are constantly looking at the numbers, you have good capacity to predict, these judgments are not that easy, right? So it is not a fault of any government. These things are not easy. You need a lot of expertise in this, and unfortunately, we don't have that kind of expertise, or at least in the right places. So, as you see, if the response begins late, then it does nothing. If the response has to begin early, then we have much better opportunities for control. Also, very often, like the lockdown or travel restrictions, nobody wants to do it, right? So you keep postponing. Why? One of the problems with ours is we start action too late and stop it too late also. Whereas we should have opened it much earlier, like schools and other things. We opened them too late. So we start too late, we stop also too late. Both are the problems, right? If you start quickly, flattens, you can go back to normal also much faster. So that's the problem with the management. So as I said, most important for picking up is to have a surveillance system. Without a good surveillance system, unfortunately, we have a program for surveillance which is called as IDSP, but it is not really good at picking up these kind of things. We are doing much better than what we were doing about 15 years back, but still our system is not that strong enough that we can pick it up quite fast. Even Nipah was actually more of a lucky break rather than the system actually picking it up earlier, right? People are saying audio is not clear, I think, in the chat box. You fixed it. Okay. Okay, this is typically what we say in the outbreak investigations. You first confirm the agent involved, describe it, find out from where it is coming, control, and then communicate. And as I said, it is always to flatten the curve. So as you can see, the epidemic phases, as soon as something comes, anticipation is through a surveillance system, then and surveillance will also help you detect it early. Once you detect, you should, if you can contain it in that place, then there is no need for, it is only a localized outbreak, you don't have to worry. If you don't do it, it will start amplifying and ultimately end up in a pandemic, right? And then we have very limited response possibilities. Okay, how much time do I have? Okay. So in any pandemic, we do 4 things. As I said, first is most important is tracking the epidemic, surveillance. Second is obviously public health measures, and Dr. Rajiv Das Gupta will talk on that. Avoid mortality and disability by getting those infected with better treatment by health system strengthening, and Anand Gupta will talk on that. And mitigate impact. One of this pandemic, especially of this magnitude, showed us that our social policies, we saw all this migration and poor people, how they've been affected by this pandemic, especially the informal workers. So we have to have systems which can quickly take care of these kind of problems, assessing the socioeconomic impact and doing something about it. So the problem is that we need to track a lot of things. Obviously, we need to not only track the disease, but we also need to track the interventions. We need to track the health system preparedness. We need to track its socioeconomic impact. So all of these things will need to be tracked, and we need that kind of capacity where we do all of them and then put all of them together and try to understand. It's not easy, but this has to be done. The problem with the pandemic, especially like this, is that when we start, we don't know a lot of things, like in COVID. See, many things are not known. Therefore, what do? We have scientific constraints. We don't know the virus very well. We don't know we don't know treatment. We don't know how to prevent it. We have our own system constraints, and you need a lot of time. We don't have that much time. If we had time, we could have done things differently. We have resource constraint, and we have governance constraints, and we'll talk a bit about that later on. So because of the pressure to act, we do a lot of things, want to do it quickly. We may not really think through the entire consequences of those response. Plus uncertainties, nobody likes uncertainties. You don't like shooting in the dark. So, and resource constraints. So all these things make an initial response to a new pandemic very difficult. These things are not going to be different if a new virus comes. We will still face the same set of problems. What is the virus? How is it spread? What is its incubation period? How much should we isolate? Why should we put our money on prevention? So initial phase of pandemic is always going to be challenging, and there will be no easy answers there. The other thing which has come up in this pandemic is the international ramifications, and as we discussed, even our global systems are not geared for managing the pandemic. I think Murli said that there is going to be a global pandemic treaty. But the way we have handled this pandemic globally, how the international agencies, including WHO and other agencies, of pandemic is far from what they should be doing, including vaccine, the sharing of vaccines with countries, how they treated the countries which reported cases, how data sharing occurred, how capacity sharing occurred. All of them was very bad in this pandemic. Currently we deal with pandemics in what is called as international health regulations. That is the way that the international treaty and pandemic influenza preparedness framework, which was started after the 2009 pandemic, which again Murli referred to. So those are the agencies or the framework with which we work, and they are clearly not appropriate for the current pandemic. My last two slides are, this pandemic also raised many ethical issues on privacy, right? We saw houses being labeled as COVID positive, put a poster outside, people got terrified, people started boycotting them, and we said that you will not come outside. We did not make any other provisions. We later on obviously learned and did some things to do this. But how appropriate is to put label against people, right? We have been, in general, you should avoid. You should not put label that he is whether HIV positive or whatever, COVID positive. We should avoid those kind of a thing. Contact tracing also invades privacy. Largely, we believe that in a pandemic situation, epidemic situation, privacy takes a bit backseat. Larger public good is more important than privacy, which is a correct. There is nothing wrong in this thinking process, but there is a limit to which the privacy can be compromised for larger good, right? There is no clear-cut barrier there. There is no clear-cut line that this is okay, this is not okay. We have to learn to deal with it as we understand things better. Digital privacy, all these apps and their data sharing, for example, consent and all these things were not done, right? Many of these things were not properly done. Many of these things we didn't do well. Again, there is a trade-off here between public good and private good. We have to have better frameworks for, largely the current framework is too oriented towards government and rather than towards privacy, right? Whether it is data or whether it is ethical, it gives more power to the government. We need to have better checks and balances in the system. Okay, so the other was again, this is the same thing, our own rights versus duties. We all maybe failed as individuals. We all had to monitor ourselves, and if we are infected, not go. We saw a lot of people, even they were infected or they were told to stay at home, they didn't go, they decided to go out, right? Health workers is the issue. Can we mandatorily make any health worker work in a COVID ward? Is it acceptable that if you have, when you signed in as a health staff, whether a doctor or a nurse, are you automatically agreeing yourself to work in a COVID ward? Or you need to take consent from people, or the institution has a right over you that we will put you, you have to work. You don't have a choice. Similarly, above 60 people were generally not posted, but that's norm. It's not necessary. It's not a rule, right? People with illness. Should vaccination be made mandatory for health workers? Should vaccination be made mandatory at all? Are issues which are not clear, right? And we also had a lot of problems in India between states. States arbitrarily making rules for people to come in to test. Completely silly and idiotic rules they were, but all state governments are fault of it. It's not one state government. Almost all state governments made some silly rules to test, to isolate, so all those kind of a thing. So we need to have better federal understanding between states. We have so porous stated borders that there is no point in, these rules were absolutely meaningless. None of them stopped the spread of the infection, except troubling the population. So ultimately, you all, obviously, as your healthcare providers, your primary job is to work in hospitals and prevent spread within the hospital setting, nosocomial infections, and ensure that infection control procedures are followed. You can also work in the screening services, identifying people who have potential infections in the frontline wards or in the OPDs. Obviously, provision of care to those admitted. Most importantly, in COVID, we needed healthcare workers to provide emotional support because there were no other people allowed to visit the COVID wards, right? No relatives or other people were being allowed, which resulted in a lot of emotional trauma to patients, and nurses were among the people who were most positioned to provide this kind of support. And maybe we are not trained for that also. That's something that we may need to look at it later. But also, I think we saw it today in the morning. Nurse administrators also stepped up, and they had also many role in terms of shaping the hospital response, which staff on training, on workforce deployment. We saw in Ames that a lot of them are actively involved in training of workforce and who will go where, etc. Those kind of things. And finally, perhaps the least taught nurses should also, which we don't see much, is nurses as researchers. We are largely more seen as a providers, not as a knowledge generators, right? So I think it is time we also start working in the area of research. So with that, thank you. I am ready to take any questions. Are there any questions in the chat box? Or, yeah. Yeah, I don't see any questions there. Okay. There is nothing, then we can.
If there is no question, we would like to end the sessions of Dr. Anand Krishnan. Thank you, sir, for elaborating such a big topic in a very short period of time and expanding a basic concept with us. Thank you so much, sir, for clearing our knowledge. Now, I would like to request Ma'am CB to kindly felicitate sir with memento and token of appreciation. Thank you, ma'am. Thank you, sir. Now, I would like to request all the participants to have a tea break and we'll be looking forward to enjoy the session. And I also request everyone to kindly assemble here before 11 a.m. for the next session. Thank you. We'll have a tea break now. Thank you, sir. एक मिनट सर मुझे अभी पहले ये शेयर करना है, फिर नेक्स्ट वाला पीपीटी करनी है। हो गया? नहीं हो रहा है भैया, नहीं हो गया। एक काम करो, ये काट दो, गूगल काट दो, आई थिंक अभी स्लो चल रहा है। शेयर कर दो। छोड़ दो, आई डोंट थिंक छोड़ दो, नहीं हो रहा है। नहीं हो रहा है, छोड़ दो भैया। क्या हो रहा है? I welcome you all again. Next, I would like to invite Professor Dr. Rajiv Das Gupta to put some light on how to control the outbreak or pandemic in peripheral healthcare setting. Sir is currently working as a chairperson of Center of Social Medicine, Community Health, JNU, New Delhi. Sir had completed Fulbright Senior Research Fellow at Johns Hopkins, and he was a visiting professor at the University of Technology, Sydney. Sir have taken a various national health policy initiative and problem evaluation and ongoing disease education elimination program. He is also a widely published in a national and international journal, and also experienced as managing editor of Indian Journal Community Medicine, managing editor of Indian Journal Public Health, and also a regular commentator in international and national electronic print media. So due to lack of time, I won't be able to completely list out all your achievement. So I would like to give this precious time to you, and I would like to call Mr. Bibin sir to kindly felicitate sir with token of appreciation. I would like to call Ms. Parul to come and facilitate sir with token of appreciation. Thank you, sir. The stage is yours, sir.
This mouse will work.
Yes, sir.
Okay. Thank you very much. What I thought, given this half an hour, is rather than trying to cover too wide an area, to focus on two particular categories of frontline healthcare personnel or staff who have very important roles, and certainly, as in the ongoing COVID, we have seen their roles, but often, and this is just to continue with Dr. Anand Krishnan was pointing to that, many a times the way the roles have been defined, or the way those have been operationalized, have really left a lot to reflect and to learn. Now, this is something all of us are familiar with. So what really are the peripheral institutions in the country? That's sub-centers, now health and wellness center sub-centers, and then the primary health centers and the community health centers. And this is what the current numbers are, these bars, if you see. So the blue one is The subcenters, the next red one or the pink one is health and wellness centers which have been upgraded from subcenters. The green one is the number of PHCs, and this violet one is health and wellness center PHCs, and this is the total CHCs. Now, what is really a positive development, if we look back over 15 to 20 years, is the considerable reduction in vacancy positions in this. Therefore, these peripheral health centers, both in urban and rural settings, today have much less vacancies, and therefore that's something which has been a very important factor or important big help in managing the COVID. Add to this, of course, the 9 lakh plus ASHAs, or the community health workers, who have really played a very sterling frontline role. And therefore, I'll confine my talk over the next 20 minutes or so largely to the roles of community health workers and nurses. So the important thing is that the roles and tasks of community health workers change substantially during pandemics. And what we have seen experienced in this COVID pandemic is that their roles were limited to one, contact tracing, of which we will see a bit, and working with the communities to raise awareness, various engagement measures, and sensitization in terms of countering stigma. And what this meant, and this we know from other data, for example, routine immunization data, there has been substantial reduction in delivery of routine, but which are extremely essential health service delivery, whether it's NCDs, monitoring, or antenatal care or immunization. And this is not about India, this is the entire world, and particularly the Southeast Asian region of WHO has experienced it. So India has been no exception, but because of a very substantial populations and substantial workloads, it's an immense task now to make up for this. The important thing about contact tracing is that the WHO guidance is very clear on this, that contact tracing is to be done by the trained epidemiological staff. Now, it's for each state or each country to organize who would actually do the contact tracing. It's only the contact follow-up component that's actually in the realm of community health workers. But this has often been, and again, as Dr. Krishnan was pointing to, in different state guidelines, this has been fuzzy or muddled up, or often contrary to this. And therefore, the community health workers, or ASHAs in our case, are not really to be involved in contact tracing, but their role is important to also safeguard essential primary care delivery at this point. Now, overall, as we know, the community health programs across countries depend on what their roles are, what their task allocation is in normal times, what their level of education and training is, and how exactly they are aligned with the overall health service system, and of course the remuneration they receive, which is, as we know, incentive based, and that has a bearing on how they would prioritize or not prioritize certain things. And given that with COVID or any epidemic or pandemic, the routine essential work is differently viewed. And therefore, there's very clear guidance on the changed roles and tasks of a community health worker during a pandemic or epidemic setting. And there are 3 cardinal points. One, that essential activities which need to be sustained, but they will also need to be sustained with some modification, reducing contact and so on. Now, that needs to be clearly set out at the beginning, or not even at the beginning, but in the planning and preparedness for an epidemic or a pandemic, to identify what is non-essential and therefore can be postponed, but then it's not because something just can't be delivered, that's why they become non-essential, but they really have to be labeled as non-essential and therefore decision taken to postpone this, and whatever epidemic activities that they need to perform. The other important point, and as you are well aware, that ASHAs or community health workers also deal with medicines, also deal with supplies, and what kind of disruption happens in those supply chains. Epidemics or pandemics of this scale always disrupt supply chains, whether it's in a tertiary care setting as this or at the front lines, and therefore managing supply chains becomes a very crucial activity. Linked to the functioning of community health workers, and remember, they are the largest numbers. If we say take the numbers of doctors or nurses in primary healthcare settings, I'm not taking the secondary or tertiary hospitals. In peripheral settings, CHWs are really the largest workforce, and therefore their issues of governance, of sustaining the financing at that point, even through the COVID pandemic, ASHA remuneration has not been has certainly not been on time. They are in general never on time, but in pandemic situation, many of the payments or the problems with payments have been really accentuated. The CHWs also, because of their frontline role, experience a lot more stigmatization than actually many of us in hospital settings do, and therefore, and this is something which is hardly ever taken into account in terms of organizing psychosocial support or peer support, and that's where the nursing leadership and the community health leadership can actually need to work together, and these can be some of the research areas that Dr. Krishnan was referring to in his closing comments. These are the areas where the nursing teachers or the nursing leadership or the nursing research community certainly need to engage with. Also, because community health workers are in very close touch with the community at large, the risk communication and the emergency response system, they often are operated and managed differently. By differently, I mean in somewhat different verticals or silos. That becomes intensely problematic at times in the front lines. And therefore, as far as a community health worker is concerned, or as far as that level is concerned, integrating risk communication into the emergency response system, that needs to be seamless rather than siloed. But it generally, as we have experienced, runs parallels or somewhat in silos, and this is something really that we need to look into for our future preparedness, or even for any major next waves that we may have. And finally, this just summarizes some of the earlier points of how do we really re-profile or recalibrate community health worker training programs for epidemic preparedness. Now, CHW training programs hardly ever address epidemic issues or even local outbreak issues. They are focused largely on maternal and child welfare programs. They are focused on NCD programs, a bit on surveillance to the extent that they act as data collection points. But as far as an integrated epidemic response goes, community health work or community health workers are not really considered very, or so far has not been considered to be very integral to that response. But this pandemic has taught us, and certainly ASHAs have played an extremely important role across all states. But this is something we need to refocus in their training programs. So, to any questions on community health workers, any clarification, I'm happy to answer at this point. Okay, if not, oh yes, sir. Or would that disrupt this? Okay, we can come back to it at the end. Okay, nursing, of course, here I'm not referring to nursing in clinical care settings of the district hospital or the tertiary care hospital or teaching institutions. That's a completely different realm. What really are the frontline roles in the institutions that we were saying, leaving aside the sub center where actually that's run by AIIMS or multipurpose workers, but PHCs and CHCs across all states have variously played clinical care roles in this pandemic, and also in future pandemics or epidemics, even limited epidemics, say such as Zika or such as Nipah, as we have seen in recent times, or any of the influenza pandemics that may come. Primary healthcare centers and community healthcare centers, particularly CHCs, or even variously across states, block hospitals or rural hospitals, those do serve as clinical care points in peripheral contexts, not obviously high-end or sophisticated care hospitals. So nurses therefore continue to be at the front line of patient care in these settings, and the primary task as the nursing professionals are to ensure that all patients acquire personalized high-quality services, irrespective of the infectious conditions, and infectious condition is a very real challenge and issue to reckon with. And therefore, as we were discussing with community health workers, it all depends with planning for outbreaks, planning for epidemics, or as in the case of COVID, planning for waves. As we speak, in the situation report of March 15th, which captures the last fortnight, which is the first half of March, today's what, 19th. So the Western Pacific region, which is primarily contributed by China, South Korea, etc., that's seeing a plus 29% increase in new cases over the previous fortnight. It's about, I think, 12% or so in the European region. Southeast Asian region, that's us. Currently, it looks comfortable at minus 21%, which means it's still in the declining phase. But that's going to change in the next 4 to 6 weeks, most likely. To what extent, we don't know. Of course, this is Omicron. Still, it's in the Omicron phase, so it's likely to be mild. But then it can also overload systems in certain states or in certain districts or in certain contexts, and therefore planning therefore is a continuous process, really, and not waiting for the next great epidemic or next grand pandemic. And therefore, the nursing profession deals very, very closely with sanitation materials, with personal protective equipment. The nurses are generally the first port of call for implementing various protocols of isolation, of quarantine, of triage, all that things were discussed in the previous talk, and therefore all of this is in the preparatory phase at the front lines. Again, I repeat, this is not about hospitals. Now, even in the front lines, there are somewhat slightly different settings. In public health settings, that is for public health nurses or many states which have public health nurse or JPH and cadres, we need to carry on with regular duties, at the same time protecting the health of both nurses as well as their patients. Nurses have been in many countries, have played very important role in managing hotlines, given that the telephone or the internet has played a very crucial role. Screening over the phone is a very important task, which in many countries nurses are performing. This also includes tracking the symptoms, referring the patients, and therefore applying referral criteria. Also, as we were listening in the previous talk, the guidelines change very frequently as an epidemic evolves or a pandemic of this nature evolves. What's a guideline today? By tomorrow it will be completely or could be significantly different, and that's where as frontline personnel, nurses or the nursing profession as a whole has a very important task in understanding, interpreting these recommendations, and then engaging with both the public or the community and the local health authorities. That's a very crucial role that the nursing profession plays, and therefore, in terms of the research agenda that he was talking about, how do we actually work with the nursing profession to strengthen early reporting networks? We rely on the IDSP, which in turn relies on various other things, but nurses really who are in touch with patients, that's never been much on the agenda of IDSP, and therefore these are important issues that we can engage with. And finally, nurses in public health settings, public health nurses have a very important role in engaging with local communities in terms of health information, health education, and community engagement at large. Even in the primary health center and community health center, they also serve as emergency room settings. Emergency room settings are not just in big hospitals. And therefore, when we deal with an highly infectious disease such as Ebola, such as COVID, and particularly those spreading through respiratory routes or secretions, nurses have a very crucial role as the first responder or the first point of contact in emergency room settings, and wherever, and this has been very true in COVID, patients have largely been brought by ambulance personnel, and therefore coordinating with the paramedics in the ambulances is also very crucial. Now there aren't really very set protocols for that, or what the rules of engagement there are. These are things which we still need to improve. Of course, going by protocols, the nurses are in ER settings are those who first stabilize the patient, provide oxygen, and so on. Quarantine, we heard in the last session. The other important role in emergency room settings is how to limit the spread of infection. Again, this is equally true of Ebola or COVID, of how we use PPE, how we actually institutionalize social distancing in those settings. These are very important challenges. The other important nursing activity that's been very prominent in this pandemic is telehealth nursing. Nurses again across worlds in different settings have actually played very important roles in supporting routine care, in providing consultation for those with mild symptoms. These are very important contributions. These help limit overloading hospitals to the extent possible, and therefore telehealth nursing is emerging. Telehealth is not just for specialist or super specialist consultation. That's something we often conflate with, or that's what often investments or systems get into. But telehealth nursing is something which is emerging very importantly, and this would have lessons or bearings for other kinds of healthcare. Also, we have learned a lot on telehealth nursing in the COVID context. And finally, the last 2 or 3 slides on what really are the responsibilities of the nurse leadership. This is, of course, more generic. This is as true as in frontline settings as well as in higher care settings. The nursing leadership really has to support the personnel at the front line, which is true of any leadership. And it starts, I go back to the same theme of planning for anticipated outbreaks. The demand for nursing services that any epidemic is going to see or forecast that. And that's obviously going to be different, somewhat different from disease to disease, whether it's Ebola or COVID. The nature of the disease or the natural history of the disease will mean that the nursing requirements are somewhat different. But that's something the nursing leadership and the nursing profession in general and the health service as a whole need to plan. Many a times, while other things are planned, the extra capacity that nursing services need to provide doesn't often get that importance. But then when the systems overloading happens, it's really nurses who face most of their task or overload, and therefore this planning needs to relate to training and supervision components. And therefore, as we go along, even in this pandemic, the training needs and the training elements do need to get refined as we go along. The other important task of the nursing leadership is actually, to the extent possible, of course, all institutions, more so secondary or tertiary care settings, but primary care settings also, all institutions are very complex entities, and it's not that the nursing leadership is the only leadership there. It needs to work in conjunction with other leaderships. But as far as providing a healthy work environment for nurses, whether it's a public health nurse or a clinical nurse or an intensive care nurse, that primarily rests with the nursing leadership. And therefore, in these very demanding contexts or situations, the nursing leadership has a very important role to not just provide an occupationally safe environment through PPEs and other infection control measures, but also to provide a healthy work environment, to encourage reporting on accidents, to encourage reporting of abuse situations, because although all of us have been involved in the COVID care, this is a very charged situation, and it comes with its own challenges and problems, and the nursing leadership therefore has an enhanced role in these settings. And finally, the leadership also needs to guide the frontline nursing staff on managing quarantine and isolation. And finally, and this goes back again to some of the last points that Dr. Anand Krishnan was discussing on ethical issues, on mental health issues of nurses, and this is equally true of all frontline personnel. And for each cadre, the leadership and the cadre leadership has a very important task and duty in providing not just occupational safety but a healthy work environment. Thank you. I'll stop here, and I'm happy to answer any questions. Should I come out of it? Thank you.
Now it's time for discussion. If you have any question or query, you can ask now. Online. So if there is no question, we would like to end the sessions. Thank you, sir, for enhancing our knowledge and covering all the aspects which we need to address in the peripheral healthcare setting. I hope this session will reach out to all the peripheral healthcare workers and will be able to help them. Next, I would like to request Ma'am Nem Khomlang to kindly felicitate sir with a memento. Thank you, sir. Thank you so much. Next, I would like to call on DICE Dr. Anand Gupta, sir, to kindly illuminate the audience on hospital preparedness to pandemic in outbreak control strategies. Sir, thank you, sir. Thank you so much. Once again, I welcome you, sir, Dr. Anand Gupta, sir, on the dais. So, दो लगा अच्छा सर which one आप कर
ओके कौन सा वाला
इसमें डिजास्टर पीपीटी बाहर कॉपी
नहीं कोई नहीं तो बाहर कॉपी कर लेता हूँ
I would like to call Miss Parul to give a token of appreciation to sir.
Good morning, all. So, I'm Dr. Anand Gupta, working as assistant professor in Department Hospital Administration. Currently, I'm posted in Trauma Center, and yesterday only we had completed one preparedness, which we know as HOLY. It's a known disaster for Trauma Center. So, I guess you are from varied hospitals, or all of you are from Ames? All of them are from Ames? Different departments of AIIMS. So it will be easier for you to understand the areas which I am going to talk about. So when we talk about the hospital preparedness, disaster, they come and they don't give you time to prepare. So there should be a plan ready for a small and even a big disaster. So there are different levels of disaster for which different graded of response are there in a hospital. So the topic is about pandemics and outbreaks, which deals with basically the infectious disease. But some background about what is disaster. Disaster means a catastrophe, mishap, calamity, or grave occurrence in an area arising from natural or man-made causes, or by accident or negligence, which results in substantial loss of life or human suffering, or damage to and destruction of property, or damage to or degradation of environment, or is of such a nature or magnitude as to beyond the coping capacity of community of the affected area. So pandemic is an epidemic of infectious disease that has spread across a large region or multiple continents or worldwide, affecting a substantial number of people. This might have been gone in detail in the morning lectures also. These are in large scales. Epidemic in number of geographical places is called pandemic. So the latest pandemic which we saw and which currently is ongoing is COVID pandemic. So some history about pandemic. The most fatal pandemic recorded in history was the Black Death, the plague, which killed about 75 to 200 million people in the 14th century. So at that time, 2 decades before, there were different types of pandemic, which was plagues, which we rarely see today. So over the period of time, the nature of the pandemics changes. And as we all know, every 100 years we see one pandemic. So the last, in 1918, the Spanish flu was also known as the 1918 influenza pandemic, was an usually deadly influenza pandemic caused by H1N1 influenza A virus. And lastly, from February 1918 to April, it lasted from February 19 to April to 1920, and it affected about 500 million population. At that time, it was 1/3 of the whole population. And currently, we are seeing pandemic of COVID-19 and tuberculosis and HIV/AIDS of different regions. So, what is disaster for a hospital? It is a temporary lack of resources which is caused due to sudden influx of unexpected patient load. So, if the number of cases increases beyond the capacity which the hospital is equipped to treat, then it is called a disaster for a hospital. Hospital needs to calculate its normal capacity, beyond which it has to act according to the disaster plan. Then the hospital treatment capacity. It is the number of casualties that can be treated in an hospital in an hour, which is usually 3% of the total number of beds in an hospital. Then hospital surge capacity. It is the number of more cases the emergency or the hospital can treat in eventuality of a disaster. So hospital surge capacity is the number of seriously injured patients that can be operated within a 12-hour period. So the surge capacity is calculated as the number of operation rooms into 7 into 0.25 operations per 12 hours. Then whenever there is surge, the concept of medical, whether it is a medical or surgical surge, forms the cornerstone of preparedness, planning efforts for major medical incidents. It is important, therefore, to define this term before analyzing solutions for the overall needs of the mass casualty or mass effect incidents. The ability to respond effectively to events producing a mass influx of patients that disrupts daily operations requires surge capacity. So the key components where we will always talk about are these 4S: the staff, that is the material and the stores, the structure, the infrastructure, and the systems. So whenever there is a surge or a disaster or a pandemic, we move under these 4 heads and augment these 4 heads to cater to the pandemics or the outbreaks. So basically, what kind of disaster we face in an hospital? So we face 2 types. One is the medical disaster, in which we have the swine flu, the dengue, which comes every 4 years, then COVID, which we are seeing right now, and sometimes food poisoning, which we have rarely seen, but it is one kind of medical disaster. Then surgical disasters. Surgical disaster, like I already told you, Holi is a known disaster. Vehicular accident, air crash emergencies, bullet and blast injuries, collapse of a building, fire. Then civil commotions like communal riots, violent agitation, terrorist attack. Natural calamities like flood, earthquake, and outbreak of epidemics. And over the year, we have seen all of these. And the main treating center for Ames is trauma center for the surgical disaster. And for medical disaster, the main focus comes on to the main emergency. That is in the main hospital. So the role of the hospital is, hospitals have a primary responsibility of saving lives. They also provide 24/7 emergency care services. and public perceive it as a vital resource for diagnosis, treatment, and follow-up for both physical and psychological care. So whenever there is pandemic, outbreaks, or disaster, then the focus always shifts to the hospital, because at that time the need is that the patients need to be treated wherever. So we're going to talk about briefly the disaster management plan and JPNATC, the disaster management plan at AIIMS, and then we'll talk about how we manage COVID in our hospital. So whenever there is a disaster, then the police calls the control center at AIIMS, and they inform that there has been a disaster and the patients are coming in AIIMS. So info is received at ED, confirmed by the senior most SR, who becomes the incident commander. So in events of any disaster or outbreaks and a large number of patients that are coming in any of the emergency, then the chain of command and a person who heads the chain of command is the most essential part. So there should be a unity of command. A single person should be ordering what should be done, how it should be prepared. So the senior most SR becomes the incident commander and sees all the inflows as per the inflow flowchart. The faculty member, also the nodal officer for management of MCI for that day, reaches the ED, assumes the charge of incident commander. So whoever is on call, the faculty on call, he comes on to the emergency and then he takes over as the incident commander. Then the chief of the center arrives in the ED and assumes the charge of the incident commander. So till that time, the senior most SR, then the faculty in charge, and ultimately the chief of the center assumes the charge of the incident commander. So we have 3 plans in trauma center. Plan A, where there are less than 7 number of patients of red area. Priority 1 are the red area patients who are critically ill, or there are less than 25 patients from same incident. So the receiving area doesn't change, it is the existing ED, and the staff, ED staff deployed at the given time takes over the cases. No extra staff is being called from the wards or anywhere else. In plan B, there are more than 7 number of priority 1 patients that are red area patients, or 25 to 40 patients. So the existing ED, and there is a disaster area in the center when you enter the trauma center, that gets activated and the staff is being called. So all the on-call residents from individual departments are called to the emergency to take care of the patients. Then staff nurse, 1 staff nurse from each nursing officer from each of the ward and ICU are called to give a helping hand for treating the patients. And on-call consultants are also called. So in plan C, when there are more than 40 patients that are expected to arrive due to disaster, then the existing ED and the disaster area becomes the receiving area, and additional area which we have as the TC1. If beds are not vacant, it is vacated, and these are kept for admissions of these patients. And in this case, all the staff which are on call plus the staff which are not on call but are on the roles of trauma center are called. So all the resident, faculty and staff nurse are called to treat the patient. So for the nursing officer, the disaster roster which are maintained by the DNS or the nursing in charge over there is activated, and according to that the nursing staff are called. And if the cases are more than 50, then it goes beyond the surge capacity of a hospital, of our trauma center. So if we are expecting more than 50 patients, then we call the PCR to evenly distribute these patients to the nearby hospitals. So beyond 50, we would not be able to cater those patients at that time. So this was about broad. If there are accidents or emergencies which are being brought onto in trauma center. So how the plan activates over there. Then the disaster management plan in Ames main hospital. These are basically those which have medical emergencies. So there is a disaster management committee chaired by the professor in charge emergency, that is the head of emergency services, and these are the other members of the committee. So any mass casualty incident in mass casualty or medical emergency in which more than 50 people are affected are taken in there. So over there, the duty officer in the control room receives the call. It ascertains the incident, time, place, nature of the incident, approximate number of casualties, and he informs the chairman of the committee, MS, and the officer in charge, professor in charge, emergency services, and activation and deactivations are ordered by the chairman. So whatever in the main hospital, we have rarely seen it being activated. We haven't had any cases of food poisoning or any other medical emergencies in the last maybe a decade or two. So committee will assemble at the MS office, which has been designated as a command center. So these are the faculty and residents which will gather to treat the patients, and optional faculty and residents which may be called in need the cases increases. Then the CNO, DNS and ANS are called along with 100 additional nurses, 50 orderlies and OTAs, and 50 sweepers are added. So the brief is given in JLN auditorium, conference room, and MS seminar room to this staff, how to deal with it, explain about the incident, what is the mission, what is to be executed, assign their duties, and command and logistic support. So the unmarked area is the major treatment area, is the casualty and the new emergency as it is, which is being there. That is the major treatment area. Temporary mortuary is set up at Jawaharlal Auditorium foyer area. Advanced life support in CNC center, OPD reception area. Then acute care area, parking in front of mortuary. Then minor treatment area, new medicine OPD block, and waiting area for relatives and treatment of critical care patient is AB8 ICU and adjacent areas of AB8 ICUs. So first step is triage, immediate stabilization, potential life-threatening injuries to be segregated and treated immediately. Walking wounded, these are less prior patient and told to wait if there are no staff. And the dead are triage as black and they are shifted to the mortuary. Then the communication from telephone and everything, these are notified. The hospital security comes into a place, the nursing unit and the hospital administrations. And supplies and buffer stocks are taken from the stores. The store people are called and all the stocks are taken from the stores. So this was about Maine, and this was hardly activated in the last 2 years. What we have seen in Maine is the pandemic COVID-19, and we are going to talk about how we manage COVID-19 in our hospital, which are pandemic. And about it started in March 2020, 2 years from now. And the first facility for COVID care at Ames was the trauma center, which was operationalized in the first week of April. It was the time during which there was complete lockdown. And during complete lockdown, there were challenges to obtain materials to convert it into a COVID care facility. Then the second wave hit, which was the deadly Delta wave, which hit around April 2021. And the third wave was in December 2021, it went by just now. So the challenge was that in COVID, the cases surged in 1 month, it came down in the other month. And the next wave came 4 or 5 months down the line. So in the interim period, to convert the COVID care facilities to make it use into a normal facility to convert it back, and then to again convert it back to COVID facility. So it was the biggest challenge for the administrators. So in COVID management, the first thing, as it was a very highly infectious disease, so the first thing was the screening area. So every patient which came to the hospital was to be screened. And there are two portal of entry in an hospital. One is through the emergency and the other is through the OPD. So there were screening areas set up in the hospital. So there was screening A and screening B being set up in the emergency. And these were the areas where there was the waiting hall for the patient, and besides this main screening area of the emergency. So two screenings were set up. One was like a green or yellow area screening where patient walked in, they had symptoms of fever, cough. They used to walk in over there, get themselves screened, and whatever treatment or admissions required were handled from there. And the other was the red, where patient required oxygen or other kind of support. So they went into screening B, where the patient and the doctor received the patient till the time COVID report came. So their treatment was being done over there. So these kind of screening facilities were set up in the emergency to screen COVID patients, and in the OPD. In the first wave, the OPD was shut down as there was a complete lockdown, and the OPD services were also shut down because there were no patients. But eventually in the second phase, a screening area was made in one of the wings, ground floor wings of the OPD, where each and every patient used to go over there and get themselves screened for any symptoms of COVID, and then they used to go into the OPD. So for any infectious disease, you have to set up a screening, both the places at the emergency and OPD. Then second was augmentation of the testing facility. In any pandemic, the most important thing, this thing is to test the people. Even if you get them screened, somebody has fever, then you have to test it. Is it because of COVID or is it because of any other disease? So you had to augment the testing facilities. So there were RT-PCR, CVNAT facilities which were being set up in the convergence block 8th floor. Then to take the test, there were facilities being made in the EHS, the old EHS OPD, where there were number of counters open to take the sample of patients, especially the EHS, because a lot of our staff also got positive and they came for testing. So special facilities were made in the old EHS OPD, where 5 to 6 counters of testing were created. And at that time, the capacity gradually increased from the first wave to second wave. Then in the main hospital, C6, D6 area, the C6, D6 ward, as you know, are the emergency ward, and patients from the emergencies are kept over there. So during the COVID pandemic, these wards, C6, D6, were kept as the holding area. If the screening area were filled or they were confirmed COVID positive, so or they were waiting for tests for more than 12 hours, these were shifted to C6, D6, where care was given till the time COVID report came. Because at that time, the facilities of testing was not there, and 48 to 96 hours also, it took 48 to 96 hours for the test to arrive. So at that time, C6 and D6 were kept as the holding area till the time the report came. If the report was positive, they were shifted to trauma center. So these were being designed to kept as holding area. So OPD, we have already discussed, a screening area was formed. Initially, these OPD was closed because of the lockdown, but during the second wave also, the OPD was not closed, but the numbers were reduced. So whenever there is a pandemic or surge, we reduce the OPD services because the most important reason is we require manpower to work in the wards. So the resident manpower and the nursing manpower are taken from the OPD, and routine OPD are reduced. So eventually online OPDs were started, and then only the follow-up cases were being seen in the OPD, and reduced number of new cases were being shown in the OPD. Then about the admission policy, similarly like the OPD, whenever there is a surge, whenever there was a surge in COVID cases, the admission policy was that no routine cases were to be taken up in the wards. So all the admissions from the OPD were blocked. This was again due to because we needed bed for COVID care, and we needed manpower, both nursing and resident and faculty manpower, to treat COVID-19 cases. So routine admissions and routine surgeries were closed down. Then the private wards. The private wards for routine admissions were closed down, and these private ward facilities were converted to COVID care facilities. We had two private wards. One was the old private ward and one was the new private ward. The new private ward was completely converted to COVID care facility, while the old private ward was kept as a backup facility, and old private ward still had to take some cases, some routine cases. So these private ward were basically designated for our EHS patients who were entitled for private ward and who were COVID positive and who needed isolation. So these facilities were dedicated for those. Then, as we all know, that two dedicated facilities. First, initially was the trauma center, and then eventually the NCI Jhajjar was converted to COVID care facilities. The whole of the trauma center and the whole of the NCI Jhajjar were converted to for COVID care. Why these facilities were chosen? These facilities were chosen because they were away from the crowd of the main hospital. So there was less footfall in the main hospital. We were treating the emergencies which were non-COVID. So to prevent mixing of both the crowds, we selected trauma center, which has a different campus, and NCI Jhajjar, which has a different campus. Then we also had to augment, because EHS facility, all the patients who are the beneficiaries, all the employees who are the beneficiaries of EHS are to be treated at Ames. So we had to augment the facilities for EHS for them during the COVID. So as I have already told you, we had increased we had taken over all the new private ward for the EHS patients. Then we had designated beds in the hospital for EHS for EHS patients. Then EHS testing facilities were created. Then for medicine, at those testing facilities, medicines were given to the EHS patients for COVID-19, those who are to be home isolated. Then preparation of operation theatre. So there infection control practices, and there was no standalone facilities anywhere which were created, because these kind of pandemics were one in 100 years type. So no dedicated or separate facilities were there. Similarly for OTs also, there were division of OTs. As you all know, there were 12 OTs in the 8th floor of the main hospital. So these were divided into 6 and 6. 6 OTs on the left hand side of the entry were designated for non-COVID, and the 6 OTs on the right side from OT 7 to 12. Out of these 7 to 12, 2 OTs were there for operations of COVID suspect cases. I'll show you the flowchart of that. Then handling staff. So as the pandemic started, as it was highly infectious, everybody wore PPE kit, and it was very difficult during that summer wave, summer period, to wear the PPE kit and to go inside there and to be packed in those PPE kit. You cannot have any food, anything. You cannot drink water. So the duty hours of the staff were reduced from 8 hours to 6 hours, and from the normal routine three shifts, the shifts increased to 4 shifts. So the number of manpower which was required to work in the COVID area also increased. And initially, the number of offs were also increased to 15 because of the quarantine requirement of the staff. And as and when we knew about the COVID virus and the COVID virus weakened, so the requirements of duty hours and the offs were also reduced, quarantine. So like right now, there are no quarantine policy for anybody doing duties in a COVID area. So staff handling, to get the resources of staff. So there were pools being made, resident pool, nursing pool, then technician pools. The pools were taken, the nursing staff were taken from different centers, from different areas where the normal work was reduced. So they were being augmented into this COVID pool, and wherever there was a COVID care facility, they were posted over there. And during the surge of the Delta wave, when the hospital beds were totally full and the number of patients were humongous, then even the our nursing colleagues from the MSc, even BSc final year, also joined to give treatment to those patients. And the strength was augmented from them also. So, when we talk about handling staff, then we have to take care about, during that time when there was the first wave, we had to take care about their food logistics, because during the first wave, when there was complete lockdown, there was no transport available, there was no shops or canteen being opened. So the Vishram Sadan building just beside the trauma center was converted into a residential area for the nursing staff which came from far by areas, and they were being accommodated over there and provided meals over there, all the staff. And special buses were run by Ames. They had taken contract from DTC, and these buses were run from Ames on a particular route, and there were about 20 to 30 buses which used to run on several routes, just for staff to take them home from duty or bring them to hospital. Then the next point is about stores preparation. So when we talk about stores, so whenever there is pandemic, we usually keep inventory in a store to meet the ongoing demand. And whenever there is surge, so we had some lead time, about 15 to 20 days, to purchase these items. So it was so to prepare during that first surge, the lockdown really helped for the hospital, because of the lockdown, we were able to get about 15 days to 1 month before the actual surge of cases to prepare for our stores. So whatever things which were required to treat COVID patients and for our staff, like the PPE kit, the drugs like paracetamol. During the first wave, there was hydroxychloroquine drugs and other type of drugs which were being used in COVID. So purchases were made, consumable items, surgical items, purchases were being made. So another challenge was the disposable of PPE kit. There was huge biomedical waste because of disposable items being used and PPE kit. So the old medicine OPD, where the OPD was run, that was converted into storing facility for PPE kit, and from there eventually the disposal was done. Then equipment. During COVID, there was huge need for ventilators and HFNCs. They were being purchased by the hospital. Then all of us know about manifold oxygen. There was a huge need of oxygen especially during the second wave, and these were augmented both in the main hospital and trauma center. In the trauma center, one liquid oxygen tank was erected and enhanced the capacity, and in the main hospital, the capacity of the tank was enhanced. So this is just the OT area of the 8th floor, where OT number 7 to 12 were converted into COVID care OTs. So the patient used to come, patient entry used to come from the lift number 18 and go out from the lift number 18. 11 and 12 were the COVID OTs. These were the staff areas. The staff used to come from the lifts in the C and D block and the AB block, and they used to go into their donning area, which was the eighth OT, and then they used to go do the sterile donning in OT 9, and then go to the COVID OTs in 11, 12, doff, and come into the changing rooms for shower and go out. So this is how the OT number 7 to 12 were converted to COVID OTs. At trauma, there were two zones, the red zone and the green zone. In the red zone is basically where the COVID infection is there, patient is there, or the patient is moving. And green zone is where the staff arrives before donning. So from donning till donning, all of it is green area. So these two separate areas, all of the COVID center was converted into these two areas, and the other green areas were kitchen, laundry, all the support services. These were the manpower deployed during COVID in trauma in the red zone. Special donning and doffing areas were being created over there. So this is how the COVID was managed at AIIMS, New Delhi, during different time waves. And as we learned about COVID, so the preparations and type of infrastructure requirement also changed. And just other infectious disease, the outbreaks, which happens regularly, is the dengue management. In dengue, we prepare for basically two things. One are the beds, and the other are the platelets. So the blood bank are kept on standby, and they were functional 24/7 to create platelets for the patients. And for beds, we take 2 beds from each ward for dengue patients, and patients are admitted over there to keep for their surge. Other are monitoring and equipment which are being pulled from other wards and ICUs. Then swine flu, it comes periodically. It also came around 2019, 2020 sometime. So in that, C6 area is generally designated as swine flu ward, where it is cut off from rest of the areas. If the number of cases are very less, then only one cubicle of C6 is converted to swine flu area. Then this is the last slide. Then the holy disaster, which it is a known disaster that there will be a surge in cases. So we prepare it 1 week back. It is about 400 to 500 cases in 8 to 10 area. Thank you. So any questions you would like to ask anybody? Okay, thank you.
If there is no question, I would like to end the sessions of sir. Thank you, sir, for your valuable information and guidance in hospital preparedness. I hope now we will be easily able to adopt the preparedness for any outbreak or the next fourth wave of COVID pandemic. Thank you, sir. Now I would like to request Ma'am Sabita to kindly felicitate sir with memento. Moving on to next, this one will be our last speaker and last sessions of this workshop. Jugal sir. जुगल सर आया कहाँ है? I request all the participants to collect the certificate after the program, because due to lack of time, I won't be able to distribute physically, so you can collect from the organization team. सर का है। पीपीटी को दिया नहीं उसने सर ने, वो डायरेक्ट लेके आया। Good morning, ma'am. Good afternoon, sir. Sir, it is on YouTube as well as in the 100. Which one, sir? It was management of chronic illness. Chronic illness and outbreak investigation. Sir, okay, sir. Ames. Incident Pandemic and Influenza Pandemic. So would you kindly take a seat? I would like to request Professor Jugal Kishore sir on the dais to kindly enlighten us on the management of chronic illness and vulnerable population during the pandemic, which is one of the most neglected population during pandemic. Well, sir does not require any introduction, but it will be my honor to highlight some of the achievement that sir has established. Sir is nationally renowned and esteemed professional of community medicine. Currently, sir is serving as a director, professor, and head of Department of Community Medicine, VMMC, Subdivision Hospital, New Delhi. Sir is a medical educator and public health expert. He has completed his MBBS, MD, PGCH, FWM, PGDE, MSc in Sustainable Development, MSc Mental Health, PhD in Psychiatric from Delhi University. Sir is also a member of more than 15 professional organizations, has more than 250 research paper publication, and a recipient of Rashtriya Ekta Puruskar, Dr. S. Radhakrishnan Memorial Teacher Award, 6 Academic Brilliance Award for Best Faculty, Honorable Director of Central for Inquiry India, founder of Sabasa Foundation and Kishore Foundation, and Secretary General of Indian Association for Adolescent Health, and President of Indian Association of Integrated Community Health, and the list goes on and on. So I would like to stop here, and sir, we are very privileged to have you here among us, and I would like to call Ms. Ritika to appreciate sir with a token of appreciation. Thank you, sir. Now I would like to give this precious time to sir.
ठीक है, देखो नेक्स्ट देखो, आ रहा है? इस पे तो आएगा लेकिन उधर क्या होगा? Good afternoon, everybody. I'm very happy to be here. And the topic is, although interesting, pandemic. Well, let's see that what is the role of nursing in pandemic, particularly when we are talking about chronic disease and vulnerable population. Rather, this is the most neglected area which we have witnessed during this present pandemic. And it is true for all kinds of pandemic, or maybe you can say disaster. We always find the sufferer is the one who is, poor and certain group. So fortunately, from the very beginning, I was part of this pandemic, COVID, and we had been in various states during the lockdown period. And I was also part of the H1N1 pandemic during that period. We have also, no, it's okay. We had many such instances where vulnerable population was suffered. So this time we'll see and look at it, that how this could have been avoided, and we could have managed much better. So there are a few things here. One is the pandemic, vulnerable population, and chronic disease. So we'll discuss each one. So if you take, movie. Pandemic, it's any outbreak, and I was looking at it, and many a time public health people are saying that pandemic or epidemic can be of non-communicable diseases. We have the diabetes and hypertension and all that. But the world over, the pandemic and epidemic word is used for infectious disease, or but we use it because the concept is very clear. When it is out of proportion or something which is beyond the control, or maybe I think it is new, so we always give the term epidemic, and therefore we say the capital of diabetes is India, because say epidemic form has emerged out of the diabetes. But actually, when we talk about pandemic or epidemic, it is infectious disease that occur over a period of maybe short period or longer period. But pandemic is usually a little longer. It cannot be just in a month something happen and gone. But most important part in pandemic, which I think most of you might be knowing, it is the wider geographical region, and that include many countries, or maybe continent, and it has to be high in proportion, so demanding something extraordinary effort. That is why the pandemic is similar to like the disaster, international disaster, you can say. And it affects a significant proportion of the world population. That's also very important. So as I told you, not should be in just 1 or 2 months, but several months are involved in it. So that becomes the pandemic. So when we talk about this, then just, you have to go in the history, and you find that why this is all happening. So we were in jungle, and we were hunters, and, just have the interaction with the animals, and then, some kind of disease started at that time. And when we actually become the agriculture, society, and more people were living together, then the, occurrence of disease in a population arise, Otherwise, if you are living scattered, so you die, something happened to you and you die, and then nothing happened to other person. But when you start living together, and then the infectious disease spread comes, and then the human population, which is having lot of trade, and then you can say the interaction between the animals, which are usually pet animal, or you can say cattles, which were there. Um, so we had the concept of zoonotics. The zoonotic disease emerged out. So many pathogens were there. And we started having the cities and development and all these things. And then the transportation become a source of transmission of these infectious disease. And if you just flash back all the history, you find that why this disease becomes so world over within a few weeks time. It never happened. Even if we take it the swine flu, it was little less as compared to this time. But when we take 100 years back, the Spanish flu came. So it took almost 2 years to reach different areas because the transportation was not very high. So situation is changing, the population is changing, the reasons or factors are changing. That is why they are becoming a proportionately very high risk to the population and also to the managers who are dealing with. So I told you about this COVID. It appeared in December, but in January, it was there in 103 countries, and then next month it was there in 200 countries. So within few months you can find everywhere. So it is just because of in few hours you reach to different countries. That could be a reason. And in 24 hours you reach to other part of the world, totally a different part of the world. That is why this was there. And it could have been limited in China, but there was a reasons, and those reasons were, focusing more on Italy and then Iran. So the religious factors were also there in the beginning, but as we all know, if people suffer in some areas, then they actually run to their home. So whoever was there in Wuhan, just rushing to their home. So they were from different part of the world, and immediately the infection reached to different part. And we have realized that in the beginning, it was actually this picture is of around April. At that time itself, they said that 8 strands are circulating. But today we know that, hundreds of strands are circulating. Why it is so? Are you aware of why this is so? We have large number of strain, and there are around 4,000 type of variations are there of this COVID. Are you aware of that? Why it is so? Mutation, yes. So mutation is fine, but why it is so fast? ये क्वेश्चन है वहां से रिपोर्टर्स भी पूछते रहते हैं. But anyway, so more divisions are there of the virus, and in different type of people. We are different from Europe, different from China, from and it is spread to different parts. So every place, every continent have their own, and we have infection in one person. In one person, you have millions of division in one, if you're suffering from. And we all know that in 1 lakh, one division is a significant, mutation occur. So more people involved, more mutations are happening. If it is limited to few, then the mutation will not be high. So more multiplication, more divisions, and more mutations. That is why in this, because the whole world was involved, we have huge number of mutations, and some of them become very serious and significant. Next issue is chronic disease. Now, chronic disease, if we list of importance, then we find so many chronic disease are there. and they are common also. It is not that they are chronic, but they are also common, like the hypertension, depression, painful back, or maybe asthma, CHD, dyspnea or dyspepsia, diabetes, thyroid, problems, and then list goes on, cancers and stroke and kidney disease, and it appeared that what Buddha says, everybody is suffering, and we found that everybody really suffering. If we learn about the number of problems are there in the community, nobody is. And when you look at this kind of proportions rate, then we find 80% of the people are having at least one chronic disease when they are above 65. So there are certain age group which are highly susceptible to, and 68%, almost you can say more than half of the population is actually having two chronic disease. So you can imagine that, and then we have other percentage like hypertension, high cholesterol, arthritis. A number is, and when we just take an example of India or China, then 1% means, again millions of people, 1%. It is not just a few number, it's a million. And they are really suffering to the people. So that is one. Another one is this one. NCD is non-communicable disease. Unfortunately, although we say non-communicable, but nothing is non-communicable. Everything is now communicable. Are you agree with this? Yes, no. Even these diseases are communicated. These diseases are spreading from one person to another because of our behavior also infectious, and it is spreading in our family, and also our group, peers, and they are all communicating. That is why I feel very uncomfortable when we say non-communicable. Anyway, so we have the cardiovascular disease. These are all leading to deaths and disability globally, affecting more people each year than all other causes combined. So number is quite high when we say NCD. And they are responsible for 70% of all deaths, and 80% of these deaths occur in low and middle income countries. So when we talk about India or maybe China or maybe some other country, then majority are actually non-communicable disease, which are killing and disabilitating and killing. So that should also be keep in mind when we talk about pandemic. Okay, what the topic was given to me. With the aging population, then we have multi-morbidity and long life expectancy, which has increased because of various reasons. Again, I need not to say what was the reason of our life expectancy, but increase of survival, and more people are expected to have the NCD, because we have seen that more than 60 years of age, you have one or two type of NCD. And because it's a chronic in nature and lifelong, or it's a prolonged, the person is having, so their interaction with the health system is quite high. They are coming more frequently to health system because they are suffering, and they require more attention, and they keep coming to. And that's what the truth is. If you go to any OPD, you'll find people are coming with these kind of problems and keep coming, again and again. Although it may be 1 month or 2 months or 15 days, but they are the. So disease management involve, access to essential medicine and rehabilitation in this group. So they are continuously requiring such kind of services. So the screening, case identification, referral system for cancers have been affected in COVID. This has been the study published, and which has resulted in substantial decrease in cancer diagnosis. So they were not able to detect it. So that's one study. Then we find, is it true for other problem also? So we find yes. If you look at the whole world, you'll find even our staff which are involved in managing these kind of problems like, chronic diseases, they are shifted from their own work to some other work in COVID. So, the question was asked, and it's a international study of the different continent. It says, yes, the all staff supporting COVID efforts full time, they were shifted. So all red you can see, they were, shifted. And in some areas, it was quite high. Like in case of Southeast Asia region, it is almost reaching to 30% of his staff full-time shifted to, some other areas or COVID areas rather than remain in the places where the chronic disease has been handled. So this is also true for partial and sometime and all. So you can find that they were picked up and sent to. And if you look at our Ames or subdivision, then we have stopped the OPDs, and the people involved in that is shifted to COVID duties, and people like us, we were shifted to some other states to look after the preparedness and containment measures. So it was true throughout the world. It is not just India. And that is what says the partially disrupted and completely disrupted services. This study says almost you can say 60%, so 60% is rehabilitative services were disrupted. Hypertension management is almost 50%. Diabetes and complication management is almost 50%. So you can see that, the last one is 40%, which is the cardiovascular emergency, which require immediately, or you cannot, disrupt cardiovascular emergency, which need to be always there. So even that is also affected. That was reaching to partial, disruption. So 40%. So you can see that we have the chronic disease which were severely impacted during the pandemic, which is the example in this study. Now, pandemic impacted our behavior also. And behavior was the reduce, stop sports, physical activity. So you increase the risk, then the increase in unhealthy nutrition, the way that we were eating at home, that increase your chronic disease, and then increase and started taking medicine to sleep at night, because in the day also you are sleeping, and at night also sleeping. So you are, because in the night you cannot roam around here and there. It was forced to remain in your home. So you can see that many of them had the insomnia, and they were started taking drug, and then increase for the anxiety and depression. They were also increase smoking, that was also there. Then alcohol is also increased, and then other addictions like narcotics and other things were in a small number, but they were started. So you can imagine that, the whole behavior, which was very dangerous and suitable for chronic disease, were also, started during this pandemic, which was created because of our decisions and whatever you can say. This was a common factor which lead to so many problems. We have shifted our work to home. So, working from home is a new normal, which they said, and which lead to many issues. We'll discuss more, and we have discussed during the pandemic about their family issues and interpersonal relationship and mental health and all these things. They were quite common. So, next issue is vulnerability. Who are vulnerable? So we have a chronic disease, and what is pandemic and how it is spread. Now the vulnerability comes. Now vulnerability is not just old person. You will find that there is a definition, and we have huge number of group which are vulnerable. Sometimes we just ignore because we don't know. Like individual who face systemic exclusion. It's a very important word. Systematically, he is, excluded from the society or from the group, discriminated on the basis of their age, disability. That's the vulnerability. And that is why discrimination comes and all exploitation come in this, based on the race, ethnicity, gender, income level, if they are poor, religious, religion, caste, creed, which is very common in our country, gender identity, again very common in our country, sexual orientation, which is totally neglected in our country, and migratory status. In addition to individuals who are caught in a conflict or in a stateless population who are incarcerated, an individual with chronic health conditions like the mental illness, people living in inadequate housing, they are also vulnerable. And people who are exposed to environmental degradation, air pollution, and at risk due to climatic change. Maybe I think disaster occur or some changes occur, then you are not able to, like the people, maybe having good food or whatever, but they are staying on the road in the night, and you start having the rainfall, then they don't have anything, or maybe a heat wave is going on and they are just on the road, or similar to cold wave. So these are the vulnerable population. Okay. Now this vulnerable population continue because they are the big social determinant of health. They are the, because of their vulnerability, health is affected. Disproportionately affect outcome of vulnerable population, which include elderly, racial or ethical minority, children and adolescents, as well as those with comorbid medical condition. These population may require additional resource and consideration in treatment of their mental health given the struggle. I was taking few days back, I think yesterday, I was in a RAK college and the topic was given trauma. Now, we understand that, Jayaprakash Narayan Trauma Center, so we always feel it is the, injury patient come, and actually injury patient come, but it nothing to do with the injury patient. Trauma is beyond it, it encompasses more of the mental health rather than your physical health. So it includes social, mental and physical. But in trauma center, you'll find only one issue, that is the physical. So we are so deformed in, we are not handling the issues. That is what treatment of people, when they require, they become, and struggle they are facing, secondary to decreased resources, healthcare access, increased mortality, morbidity, lifestyle disturbances at crucial developmental time, like in young age, where the development is so important. And that is true for our, children, which are actually not going to the school during the pandemic time. So that was very crucial development time, and a host of other factors contributing their vulnerability to the effect of the virus or maybe bacteria or whatever you can say. So that is vulnerable population. So in vulnerable population, many of the pandemic preparedness plan that exist before COVID-19 didn't have detail about how the response could address the need of the different vulnerable group. Now you can have very good plan, which was there. We also prepared for the subsidizing hospital, but we never thought of these all things कि chronic disease का क्या होगा. हमने कभी सोचा ही नहीं, और जब वो लॉकडाउन लग रहा था तब भी नहीं सोचा, और वो जस्ट ऐसे ही चला गया, और उसमें कम से कम 1-2 महीने तो ऐसे ही चले गए. उसमें कितने लोगों की डेथ हुई. इवन हमारा tuberculosis, we have gone down of the recognition or screening of the TB patients, and they were not able to take their drugs. And abhi ekdam, we have upward trend. So actually, our all plans were not addressing the vulnerable population and chronic disease. That is why they are at higher risk. People who are marginalized before the coronavirus appeared, such as the migrant, poor communities, and disabled people, were disproportionately impacted by the lockdown and the response, deployed to tackle the health crisis. So that was a condition created by some of the decisions taken during the pandemic. This time highlighted that we had a vulnerable population which has impacted hugely. Now the close down, actually closure of a school, college, offices, restriction of movement, physical distancing, masking, restriction, social gathering, they are all affected our, vulnerable population because of the action which was there for almost, I think, more than 2 months and continue for in between. And wherever the containment measure were there, those all communities suffered. So this lockdown, actually, you can see that it was empty and roads were empty and such kind of barriers were creating problems. So अगर आपको लगता है कि किसी को हार्ट अटैक हुआ हो, उसको हॉस्पिटल पहुंचना है, तो कैसे वो बेचारा उतर के इसको कैसे हटाएगा? आपने बैरियर ही लगा दिए बिल्कुल कि निकल ही नहीं सकते आप, है ना? आपकी एम्बुलेंस भी इधर खड़ी होगी तो उसको कैसे उठा के लाओगे पेशेंट को? तो वो एक practical issues. And then all were full of our COVID patients. So ना ट्रॉली है, ना कुछ और है, ना एम्बुलेंसेज हैं इन पेशेंट के लिए जो हमारे क्रॉनिक डिजीज वाले थे या एक सिग्निफिकेंट ग्रुप था जिससे मॉर्बिडिटी एंड मॉर्टेलिटी ज़्यादा होती है. सो दीज आर ऑल सीन. वी हैव सीन ऑक्सीजन चाहिए होता हमारे COPD पेशेंट के लिए, वो उधर से हट गया. अब ये वाला इम्पॉर्टेंट है देन योर COPD, बट COPD ऑल्सो सफर when we have an asthmatic attack or maybe I think COPD is there, then how you are going to manage when? So they died, and unfortunately many of them died because of this. So COVID से कम मरे, इनसे ज़्यादा मरे, है ना? हम अभी भी कह रहे हैं कि नहीं COVID से डेथ हुई, असली में डेथ ऐसे हुई कि जो जिनको चाहिए था उनको नहीं मिला, और सेकेंडरी जो हमारा कोमॉर्बिड कंडीशन थी उन्हीं से डेथ हुई. देन हमारा जो हेल्थ स्टाफ है, we have done a study also on mental health issues, and we find our all category of workers, nurses को ले लो, doctors को ले लो, हमारे technicians को ले लो, सब में burnout and exhaustions and they were there. Financial जो implication था वो already known है. अब इसमें ये सारे जो vulnerable population suffer करेगा. What was their financial? Real estate and professional services go down 17%. Mine and quarrying was stopped. Electric, gas, water supply and other utility services go down. Construction was stopped. Trade, hotels, transport were all closed down. You can imagine, I have seen people working in hotels. They had very tough time. They were almost close to 1 year. And then even the nurses, working in small nursing homes, they were just gone. They were thrown out. Because these all nursing homes were closed down during that period. Agriculture, administration, all has gone down. So that leads to so much depression in the employment. And we have unemployment, very high peaks, and that was a big problem. So we had these people who are daily wagers. You can imagine if the daily wage is not available, how they are going. वो तो रोज का बेचारे कमाते हैं, खाते हैं. अब उनके लिए डेली वेज नहीं है, तो आप क्या दे रहे हैं? हफ्ते में कुछ 5 किलो चावल या कुछ. आई वॉज देयर इन इंदौर एंड दे वर सेइंग कि हम 15 दिन से चावल और दाल खा रहे हैं. 15 दिन और कुछ है ही नहीं, सब्जी इज नॉट देयर. चावल दाल बस जो मिलता है उसमें, और एक दाल भी वो बड़ी अजीब सी केसरी दाल, उसी को क्योंकि वही मिल रही थी फ्री में तो वही खा रहे थे. So we had this, and then this calamity which was there of our migrant labor, which started moving from cities to there, and it was again we were not able to. तो ये तो एक ऐसे क्राइसिस हुए जो हम पैंडेमिक पे सोच भी नहीं सकते. अब हमें सोचना पड़ेगा, लिंक करना होगा. अभी हमारे को जो फ्यूचर प्लान्स हैं वो हमारे ऐसे होने चाहिए कि हम ये सारी चीज़ें सोचें, है ना? ये नए जो हमने शायद H1N1 में स्वाइन फ्लू में नहीं सोचा या उसको अच्छे से हैंडल नहीं किया, या उसके बाद में जो प्रिपेयर्डनेस होनी चाहिए थी वो नहीं हुई, उसकी वजह से ये सारी क्राइसिस हुई अभी. सो exodus of the labor from major cities, it was horrible. जस्ट ये इसका तो विज़न ही इतना ख़राब है, और जो लोग इसमें रहे होंगे उनका बताइए क्या उनके साथ में रहा होगा. सो द हेल्थ सर्विसेज आर लिमिटेड एक्सेस टू हेल्थ इंश्योरेंस, क्योंकि कोविड था ही नहीं उसमें इंश्योरेंस में तो आप कैसे लोगे? तो वो सफ़र किया. लो एंड मिडिल इनकम कंट्री विदाउट यूनिवर्सल हेल्थ कवरेज. जो यूनिवर्सल कवरेज होना चाहिए था वो नहीं है. और इंश्योरेंस आपका अवेलेबल नहीं है क्योंकि वो डिजीज इंक्लूडेड नहीं है उसके अंदर. And then reduce younger people's opportunity to access appropriate and timely healthcare and services, which is now required. We know that this is the need of the hour. Whenever we had the pandemic, it should be ensured by the government in whatever way is possible. Disruption of health services lead to young people who need essential, time-sensitive, and life-saving medications and services. Not being able to access them. That's the problem. अगर हमारे पास में हॉस्पिटल है, सब कुछ है, लेकिन जैसे हम प्राइमरी हेल्थ सेंटर की बात करें, बंद हो गए. हमारे हॉस्पिटल जैसे एम्स जैसे, उसमें ओपीडी बंद हो गई. अब इमरजेंसी सर्विसेज में आते हैं तो वो ओवर क्राउडेड है, वो कोविड से ओवर क्राउडेड है, तो वो कहाँ जाए बेचारे. तो ये जो एक्सेस ही बंद कर दिया. अब एक्सेस ही नहीं होगा तो फिर कैसे आप आगे बात करें. तो कॉम्प्लिकेशन हुए, डेथ्स हुई, वो रीजन रहे जिसमें अब ये एडोलसेंट के ऊपर हम फोकस करते हैं कि उनके ऊपर क्या इफेक्ट हुआ हमारे पैंडेमिक का. सो इसमें अल्कोहल यूज जस्ट बिफोर कोविड एंड ड्यूरिंग कोविड देखो कितना इंक्रीज हुआ, 1.2 to 1.22. That's not significant, but the positive rank and negative rank you can see smoking increases a little bit, and then nicotine use and substance. So 1.08 to 1.13. Small increase, but in a larger population it has and they are significant. Like, smoking was significantly higher, reached higher level during the COVID in adolescent. This is the adolescent. Now, isme dekho, social media sites increase manifold, which is, you will say it's okay because they were finding all this, but what is important is gaming is increased. Streaming services like, viewing increase, and shopping side will also increase. So they are showing that adolescents indulge into those things which are affecting their anxiety and also eyesights. So सब में इफेक्ट हुआ. ये स्टडी पब्लिश हुई. उसके बाद में लाइफ स्टाइल प्रॉब्लम which I have already said about non-nutritional food increase, screening time, sleeping hours, as well as a decrease or lack of physical activity. पार्क बंद कर दिए. I was very surprised why the parks were closed down. And even जब ये कम भी हो गया तब भी नहीं खोलने को तैयार है. तो बच्चे कहाँ खेले. अब फिजिकल एक्टिविटी नहीं हो रही है तो क्या होगा बच्चों का, जबकि इट इज कंपल्सरी बाय द साइंस दैट दे शुड हैव. जो यंग बच्चे हैं उनको एटलीस्ट 1 hour to 2 hours तो खेलना ही है. बड़ों को आधा घंटा है तो उनको तो 2 hours तो खेलना है फिजिकली, ये नहीं कि गेम खेलना है उन्हें. So they are all known during the lockdown. Then this is another study showing physical activity, inactivity, insufficient physical activity. कितना परसेंट बढ़ गया, सब सिग्निफिकेंट लेवल पे. टोटल स्क्रीनिंग टाइम, लेजर टाइम, स्क्रीनिंग टाइम, शॉर्ट लॉन्ग दोनों बढ़ गए. तो दिस इज कितना है, हो गया, चलो बंद कर देते. नहीं था 5-10 minutes. अच्छा, okay. So pre and during the COVID, the depression and anxiety, you can see the curve is self-explanatory. The feeling like, in children, feeling worries, helplessness, fear, nervousness, anger, all these things were more in quarantine groups as compared to non-quarantine group. So quarantine itself, increases many of these things which were affecting their mental health. Then this is various kind of studies showing the mental health effect, depression, anxiety, maltreatment. And what is more important here is the confinement, likelihood of the violence towards the young children, young population. इसमें जो फीमेल है इनके ऊपर बहुत क्राइम हुए, है ना. जो एक स्टडी में पाया कि ऑलमोस्ट एक दिन में करीब 1000 के करीब उनके कॉल्स, बच्चों के कॉल्स आए, यंग एडोलसेंट के, रिगार्डिंग द सेक्सुअल हरासमेंट एंड इन कन्फाइनमेंट. कन्फाइनमेंट इज इंक्लूडिंग देयर होम. सो ऐसे लगता है कि नहीं, ऐसे नहीं हुआ होगा, लेकिन सच्चाई ये है कि कॉल जब आ रहे हैं तो ऑब्वियसली कुछ ना कुछ तो प्रॉब्लम है. So violence against girls, boys, and their menstrual hygiene issues, and leading to child marriage. वो आपको लगेगा कि ये कैसे हो गया, लेकिन चाइल्ड मैरिज कई गुना बढ़ गई कि भाई पढ़ना नहीं है तो चलो अब तुम्हारी शादी कर देते हैं, तो शादी कर दी गई. So the human right issues, environmental, all these issues were affected. So child marriage increased manifold. ये सब एविडेंस है, ये मैं ऐसे ही नहीं बोल रहा हूँ कि अपने आप से ही, सब रिकॉर्डेड एविडेंस है. तो यू कैन सी दैट हाउ मच. देन क्राइम, ये वाला है, रिसीव 92,000 कॉल विच इज क्वाइट हाई इन वन डे, चाइल्ड अब्यूज वायलेंस के. ये इंडिया हेल्पलाइन, चिल्ड्रन हेल्पलाइन डाटा है, चाइल्ड लाइन. So cybercrime against children, cyberbullying also increase in urban areas. So this is all, which we have learned that impact was huge and we have to plan ourselves. So there are two big areas where, and I think before me, Doctor has explained about the plan at the hospital level. So when we say hospital level, it is the medical preparedness on one area only. But we have the health preparedness is required. नहीं, हॉस्पिटल से ही हेल्थ नहीं मिलती, उसके अलावा भी बहुत सारा एरिया है जो हमारे को पब्लिक हेल्थ के अंडर में आता है, वो हमारे को करना होगा. हमारे प्राइमरी हेल्थ सेंटर, कम्युनिटी हेल्थ सेंटर, जो हमारे आंगनवाड़ीज़ हैं या हमारे और दूसरे जगह हैं जहाँ पर वो अपना ANC कराती है या फिर अपना टेटनस टॉक्साइड लगाती हैं, वो सारे जितने, तो हमारा रिस्क असेसमेंट होना चाहिए, हैजार्ड मैपिंग, कैसे कौन से एरिया में कौन से लोग मिलेंगे. जो हमारे डिसेबिलिटी होम्स थे या ओल्ड एज होम थे या फिर जो हमारे ऑर्फनेज होम थे, उन पे हमारा ज़्यादा फोकस होना चाहिए था. या फिर ऐसे एरिया जहाँ पर एक स्पेशल ग्रुप के लोग रहते हैं, तो उसको हमें ध्यान रखना है. So then only we can, handle overall. Otherwise, just focusing on hospital is not a good idea. So you can see that pre-disaster we have to make a plan in which we have to engage the community, and now we should have a good proper plan of the health resilience. Sustainable community actions is required. So more interaction with the community is required. Now we have to define our goal, priorities that future, if we have, maybe I think third world war may be there, so we have a nuclear disaster, we can have many more other things. So are we prepared for that? हमारे घरों के अंदर बंकर हैं, हमारे घरों के अंदर ये सारी चीजें हैं कि हम अगर कल शुरू हो जाती है तो क्या करेंगे, तब शुरू होगी सर करना. नहीं, कितने लोगों की डेथ हो गई, ये सोचिए आप, क्योंकि वी आर नॉट प्रिपेयर्ड. Then organizational governance structure is required. Maybe I think law is required. Our all system, like एक मिनिस्ट्री के अंदर एक पूरा सेटअप चाहिए कि हमें इस तरह से जो डिजास्टर होते हैं या फिर मेडिकल इमरजेंसीज होती हैं, उनको कैसे हैंडल करना है. फिर वी हैव टू improve our health plans, not only just for the medical side but also health side, and then comprehensive plan to be made. And then recovery plan is also required, and learning from that कि अभी जितना हो गया उससे अब क्या लर्निंग हुई, तो वो सारा लिखना चाहिए, लिख के उसका प्लान में उसके अंदर डालो उसे. ठीक है. सो ये एक्टिविटी कभी रुकनी नहीं चाहिए, है ना. कैसे हमें उनको इम्यूनाइजेशन देना है या फिर NCD, हाइपरटेंशन, ये कंटिन्यू जिनको दवाएं चाहिए. ये कितनी बार ऐसा हुआ फ्लड के अंदर, जैसे केरल में हुआ या फिर हमारे उसमें कश्मीर में हुआ, तो डायबिटीज़ के पेशेंट तो बहुत है उधर, और डायबिटीज़ के पेशेंट को 3-4 दिन तक दवा नहीं मिलेगी तो क्या होगा, तो शूट करेगा ब्लड प्रेशर और फिर उसी से प्रॉब्लम होगी. तो ये तो इतना हमारे को अरेंजमेंट करने की ज़रूरत है, चाहे कुछ भी हो, है ना. डिजास्टर नहीं तो और बढ़ जाएगा या बिगड़ जाएगा. तो डेथ जो ही वो, फिर हमारा RRT लाइक रैपिड रिस्पॉन्स टीम है, उसको अच्छे से काम करने की ज़रूरत है. वाटर सप्लाई during this period is required. Then sanitation and hygiene is required of the whole area, which are leading to safe excreta disposal, waste management, and the vector control, immunization. So you can see that in the end, we have the surveillance and monitoring has to be strengthened, the containment and control like the, contact tracing, hygiene, quarantine. हमने क्वारंटाइन, हाइजीन, कॉन्टैक्ट ट्रेसिंग के लिए किनको लगाया? टीचर्स को लगाया, आशा वर्कर तो बहुत कम थी, टीचर्स को लगा दिया बेचारा। तो कहते हैं इमरजेंसी में होता, अरे टीचर को लगाया तो पहले सिखाया उनको और स्टार्टिंग में तो दे वर नॉट हैविंग पीपी किट नहीं था उनके पास, और क्यों जाएंगे फिर? तो बस ऐसे ही किताबों में चल रहा है या पेपर में चल रहा है कि हम ये कर रहे हैं वो कर रहे हैं, तो हुआ नहीं कुछ। सेव लाइफ्स, लाइक ट्राइज सिस्टम, सर्च, कैपेसिटी कैसे करनी है, और वो आई थिंक अच्छे हॉस्पिटल में अच्छे से हुई है ना, हमारे जैसे एम्स वगैरह में अच्छे से उन्होंने एकदम सर्च कैपेसिटी को करके, बट वो बंद नहीं करना चाहिए था, मेरे को ऐसा लगा। और कम्युनिटी रेजिलियंस, लाइक प्रोटेक्टेड वल्नरेबल पॉपुलेशन, सोशल डिस्टेंसिंग जो है वो आपने की, सिक्योरिटी, वी हैव टू, एसेंशियल सर्विसेज, इनकम बिजनेस, इकोनॉमी, ऑल दीज थिंग्स रिक्वायर्ड. So you can see the research, recovery and reflect should continue throughout various, areas. So lot of research is required in this area, and lot of activities are required. Coordination with the community and good communication is also required. So NCD, you have taken very good area, and vulnerable population is also taken very nice. So legislation may be, I think, required for some of the issues to handle it. So this is my book. Anyway, thank you very much. The secret of crisis management is not good versus bad. It's the preventing the bad from getting worse. That we know that it's going to have the problem, but we could have saved life. That's the purpose of pandemic. So thank you very much. Any question?
Is there any question from the audience? So we would like to end our session here. Thank you, sir, for those valuable teaching, priceless lesson, and expanding our knowledge and updating on COVID-19. I believe all of us have gained a knowledge and information regarding how to take care of pandemic for futures. Thank you, sir. Now I would like to call Ma'am CB Ma'am to kindly felicitate sir with memento and certificate. Thank you, sir. Thank you so much, ma'am. Now I request our usher to escort, sir. Thank you so much, sir.
No question. जल्दी छोड़ ऐसे क्वेश्चन हमेशा पूछते हैं.
Now we have come to the end of our session, so I would like to call Mr. Bivin to read out the reports of today's workshop. Please kindly fill the posters and the feedback form.
Give me good marks. क्योंकि आपने नहीं क्वेश्चन पूछा.
Good afternoon, all faculties and delegates. Today we are going to end our session with a report reading, and after the following with a valedictory session. And I am coming to here to read the report of today's. The workshop started at 9 a.m. with inauguration session, and the first session was taken by Professor Anand Krishnan regarding the public health. He is a public health expert in community medicine, and he talked about various communicable diseases and its transmission and its control measures, how we can control the strategies to be taken to prevent the communicable diseases. And the second session was taken by Professor Rajiv Das Gupta. He is a renowned professor and chairperson of Center of Social Medicine and Public Health of Jawaharlal Nehru University. And he talked about the rural healthcare system and the role of community health workers in preventing the and control measures to prevent outbreaks and epidemics. And the third session was taken by the Dr. Anand Gupta. He is assistant professor in hospital administration. He's talked about the hospital preparedness and how the AIIMS manage the patients with COVID-19 and how AIIMS is prepared the trauma center to receive the COVID-19 patients, and regarding the how to manage the transport of healthcare workers during the lockdown period. And the last session was taken by Professor Jugal Kishore sir. He was the director. He is the director professor and of community medicine in Safdarjung Hospital, and he talked about how to manage the vulnerable population during the pandemic and during the pandemic. And we have conducted two pre-test and post-test, and the pre-test score was around, average score is 4.84 out of 10, and the post-test was 5.65 out of 10 score. And thank you for coming and joining with us this in service education program. Now I just hand over to the moment.
Thank you, Mr. Bivin, for the report reading. Now I would like to call Ma'am Sabita to kindly give a vote of thanks for the program.
Good afternoon, everyone. Good afternoon, all the dignitaries, dear participants, and all those who have joined this workshop online. It gives me immense pleasure to propose vote of thanks on behalf of chairperson, coordinator, and organizing team of today's workshop on managing outbreaks, pandemics, and endemics. I would like to express my sincere thanks to our director, Dr. Randeep Guleria, for permitting us to conduct this workshop. I must mention our deep sense of appreciation to our distinguished chief guest of the day, Dr. Murli, Chief Operation Manager, Crisis Management Branch, UNEP Geneva, for his valuable time and encouraging address. I would like to express proud thanks to our special guest, Ms. Pushpalata, Nursing Superintendent, NCI Jhajjar, Ames, Delhi, for her presence, support, and words of wisdom. I extend my sincere thanks to our principal, Dr. Lata Venkateshan, for her unconditional support, encouragement, and guidance in conducting today's program. I would like to express my sincere thanks to our senior most faculty, Dr. Deepika Khaka, Associate Professor and also MSc Coordinator, College of Nursing, Ames, New Delhi, for her esteemed presence and always supporting us in our program. I would like to thank Mrs. Sibi Riju, Coordinator for today's program, for her constant support in organizing the program, coordinating this event, and arranging for all the logistics of this program. I thank the organizing team, Mrs. Name Column, Tutor College of Nursing, Ames, in organizing this event, for her constant support and tireless efforts in arranging today's event. I would like to thank all the faculty from College of Nursing for coordinating their efforts in organizing today's workshop. I would like to thank MSc students for their tireless and united efforts for organizing all the resources for today's program. I would like to thank all the esteemed speakers who shared their knowledge today. I would like to thank all the participants who have joined us physically and also who have joined or connected online also. I thank all the staff of said facility for all technical support and arranging logistics required to conduct this program. I would like to express my sincere thanks to Ames Cafeteria for providing food for this program. Thank you everyone and have a wonderful day.
Thank you, ma'am. Thank you for the word of thanks. And now our workshop has come to end. I request everyone to kindly have a lunch. We have prepared lunch for everyone, and kindly collect a certificate after lunch from the organization team. And please submit the feedback form. Thank you so much. I sincerely thank you all. Have a great day.
Please have your lunch. After you have your lunch, please come and collect your certificate. You enjoy it?